body system that we're going to deal with is the cardiovascular system. This is this.
Now it just started working.
Okay. So technical difficulties. Okay, so this system is made up of the heart, the blood vessels, capillaries, and this is how blood moves throughout your system. Now, we talked a lot about this with pulse and with blood pressure. Thanks. So we've learned a lot about this with pulse and blood pressure. If you don't get good blood flow, areas of your body, the cells will actually die. So having an impaired cardiovascular system is actually really important. Can have a lot of effects in a lot of different areas of the body. So when we have people that have heart problems, we really kind of have to pay to all body systems because they're all going to be affected in some way. But some of the changes that we see in this system with aging specifically is going to be decreased endurance. Now, for instance, you've got somebody who used to be able to walk 4 miles a day with their job, no problem. And as they age, that becomes harder and harder. And then it goes down to like 2 miles a day. And then it's 1 mile a day. And then it's, oh my gosh, I got to walk to the kitchen. So a lot of your patients may have decreased endurance. And this is important for us because remember, we help patients with all of their ADLs, things they do every day. So imagine how many times our patient's going to have to get up and go to the bathroom. Or if they're getting dressed and need grooming. So if they have decreased endurance, they may not be able to do all of those things at one time like you do. You get up, you go to the bathroom, you bathe, you groom, you dress, you do it all at one time, and your endurance is just fine. But as we age, we may not be able to do all of those things at one time, at the same time, because we just don't have the endurance. We need a rest break. Does that make sense? So we're going to have to adapt what we're helping our patients with based on their level of ability, which means we might get somebody up into the bathroom and then in a chair to rest, go take care of somebody else, come back and let's do their grooming and their dressing. Leave them in the chair, go take care of somebody else and come back and finish up. And just give them those rest breaks in between because they may not have the endurance to do everything all at one time. Very common as we age. Higher blood pressures, we're going to talk about this a little bit later today. I've got a visual I'm going to show you that explains why this happens, but it's very common for blood pressures to be a little higher as we age. Prolonged bleeding, this happens. We're going to learn in just a minute that the skin becomes very fragile, very thin. It loses elasticity as we age. So skin tears, very common, very common. Just bumping against something, you can end up tearing the skin because it's like tissue paper. And those skin tears can bleed and bleed and bleed and bleed. And you're going to be like, oh my gosh, stop bleeding. Well, that's actually very, very normal for aging. We get that prolonged bleeding because we don't produce as many platelets to clot that off. And those platelets can't get to the area as well because the arteries are gunked up. And we just a lot of factors that lead into prolonged bleeding. So when we're working with older individuals, especially those with very fragile skin, we really want to make sure that we're using special care not to injure them in any way, because if we do, that bleeding may take quite a while to stop. Fragile veins, very common as you age. The elastic fibers that make up those veins, they just tend to kind of break down and those veins become very fragile. So just a simple bump, your patient can have, it just looks horrible. It's like red and purple blotches all under the skin. And that's just because we bumped the vein. The vein just kind of gave way. All of that blood went out of the vein and into the tissues, and it looks like a big old bruise. So very common. Oops, nope, come back here. Respiratory system. This is made up of the lungs, the bronchi, the pharynx, all of the breathing apparatus. as we age, this system gets affected too. And this is all about elasticity again. When you breathe in, your lungs are inside a cage. You've got ribs all the way around. You got a spine in the back and a sternum up front. So these lungs are actually kind of stuck in a cage. Well, in order for you to take a deep breath and expand those lungs, we have to have some give in that cage. It's got to be able to expand with our lungs. And we have some cartilage in there that helps that happen. So as we age and that cartilage gets harder, more like bone, do you think your patients are going to be able to breathe deep? Probably not. So that's going to affect their oxygenation status. Good. Again, we got that less endurance. Remember, we had that with our cardiovascular system. Well, the cardiovascular and pulmonary system work together. The heart pumps the blood, but that doesn't do anything if there's no oxygen in the blood to be pumped. So these two systems have to work together. So less endurance, very common. Shortness of breath, very, very common as we age. So you might be able to walk the patient to the bathroom and be like, why are you out of breath? You've walked like 20 feet. Well, it's because of the aging effect of these body systems. Endocrine system. This is one of the most overlooked systems of the body. And it really is the one that controls everything. Everything. Your endocrine system is made up of glands that produce hormones. And when we talk about hormones, we tend to think more along the lines of sexual hormones. And those are all just very, very, very small amounts of hormones that are in your body. Your thyroid is a hormone. Your pituitary is a hormone. Insulin for food metabolism is a hormone. Your blood pressure is affected by hormones. The amount of water that you retain is affected by hormones. Hormones affect absolutely everything. Everything. And we tend to think of the brain and spinal cord as kind of the master of, the body. But without the endocrine system, that brain and spinal cord can't do anything because this is kind of the messenger system. So as we age, those hormones tend to diminish. Now, we kind of know that a little bit when we think about sexual hormones. We end up with menopause and menopause. But hormones are going to be decreased in all of these categories. So we may find it harder to lose weight because our thyroid is being affected. We may find it harder to regulate our fluid balance because our adrenal glands are being affected. So all of these organs that produce hormones tend to be affected by the aging process. And this is probably going to lead to sleep disruptions. Now, this was one of the most, sorry, I'm going to turn check the air here. This was one of the most surprising things to me as I was learning about hormones. Okay, it is on. Okay. This is one of the most surprising things to me. I am a sleeper. I like to sleep. I don't sleep very well, but I like to sleep. And I will stay in bed until 10 o'clock in the morning if you let me. If I have nothing to do. I like to sleep. When I was younger, I used to be able to sleep till like noon. It's awesome. Not an early riser. As you age, you actually need less sleep. So you might expect to put your patient to bed at about 8 o'clock at night, and you think they're going to sleep until like 6 o'clock in the morning. Nope. They're going to be up at 2 because they require less sleep as they age. So this was really surprising to me. And this is probably the biggest issue with CNAs that work the night shift because they expect a quiet shift. They expect that all of their patients will be in bed sleeping and not require a lot of care. And it's very surprising to them that at like 2 o'clock in the morning, half of their patients are up. And they get frustrated and mad. Go to bed. You're supposed to be in bed. If somebody doesn't want to be in bed, you can't force them to. That's their right to be up. Does that make sense? So generally speaking, they're going to require less sleep all at once. Now, they may need naps during the day, so their sleep might be spread out over the 24 hours. But they generally don't sleep a whole lot all at once. Of course, there's outliers on both sides. Remember that. Decreased bone density, very common because this is controlled by hormones as well. And a reduced metabolic rate. That means that we're not going to be able to process food as well, and we're not going to be able to create body heat as efficiently. We talked about body heat as we age. Remember, we don't have that fat layer to hold in our body heat. Well, if we're not producing a whole lot because of that decreased metabolic rate, that can really leave us feeling cold all the time. We have the urinary system. Most people are pretty familiar with this. We're going to get into the urinary system in detail at the end of next week. But some of the changes that occur here is that the bladder doesn't hold as much. So my best friend, I swear she's a camel. She travels a lot. She drives a lot. And she can drive like 9-10 hours without ever stopping for a bathroom break. At like 6 hours, I'm like, can we pull over? I can't go that long. So your bladder, the capacity that you have as you're young, will probably diminish a little bit as you age. And it's just simply because you lose that muscle tone in that area. Because you've lost muscle tone, when you pee, your bladder kind of squeezes to push out whatever pee is left in there to completely empty it. Well, as you age, that muscle tone gets diminished, so we may not empty completely. So now we're starting with a bladder that has some urine in it. So we're going to have to go more often. And this is important for CNAs to understand because your patient might ring the call bell, I need to go to the bathroom. You get them up, you take them to the bathroom, get them all situated, get them back to bed. And then 2 hours later, they're like, I got to go again. Now, you are able to hold it for like hours, and you might get really frustrated with your patient, like, I just took you. Well, it's because they have decreased capacity and incomplete bladder emptying. So, yeah, they got to go. Don't put it off. Now, the other part of this that's not up here is that a lot of times, we're going to talk about this next Wednesday, that valve at the bottom of the bladder loses tone. And if that bladder gets too full, whatever's in there is going to come out because that valve can't hold shut very well. If somebody says, I got to go to the bathroom, they mean now, not 20 minutes from now. They mean now. So this becomes very challenging to try to juggle this with all the other patients' care that you have to do. So what we do in a lot of settings is put patients on what we call scheduled toileting. So that means that every 2 hours around the clock, we're taking that patient to the bathroom. So you might be at 2, you might be at 2:15, you might be at 2:30, but we're going to take you to the bathroom every 2 hours to try to help with that muscle tone issue. It also helps prevent those call light interruptions as well. Integumentary system, we talked about this. This is skin, hair, nails. Nails become more brittle. Skin becomes thinner and less elastic, more prone to tearing. We lose that fat layer underneath our skin. We get changes in hair color. I got to go to the salon and get mine done, right? We tend to go gray or white. Decreased hair production as well. And then we end up with pigmentation issues, which I just find hilarious. When you're young, your skin is pretty even toned, right? Your skin knows where to put the melanin. As you age, it gets a little confused, takes some wrong turns, and you end up with these dark spots that just appear out of nowhere. It's like, I never had that before. What is that there for? It's just like the body just puts all of the melanin, I'm just going to put it all here for now. I kind of look at it as shoving a whole bunch of stuff into a closet when somebody's coming to visit. I'll deal with this later, right? That's what happens in the body with all of this melanin. They just kind of shove it in one place. I'll deal with it later. So you end up with these skin tone issues. Now, for most people, this isn't an issue. It's part of aging. But for some people that are very, very image conscious, this can become a very big deal and very distressing as well. So we have to remember that we're dealing with people that have a lot of different outlooks on life. So for some people, this could be very, very concerning and really affect their self-image. Other people are like, whatever. Reproductive system, this goes without saying. The reproductive system also ages. We end up with menopause in women, which is a decrease in hormone production, a decrease in fertility, the ability to have children. We also get hot flashes and night sweats as those hormones tend to fluctuate. Decreased moisture production and erectile dysfunction are common. Thinner skin, things like that. The one thing that I do want to say about the reproductive system, though, is that just because it's affected doesn't mean it's dead. Okay. As we age, sex drives still exist. And you may have patients that engage in some sort of sexual activity in facilities. If you notice something, you have to report it. It's not, we don't look at it and go, oh, how cute. If you notice, you report it, because now we have to look at capacity and the ability to give consent, because we don't want a situation where we have somebody that's not able to consent being violated. Okay. Does that make sense? So if you notice something, say something. Don't assume that all old people are not sexually active. Yeah, the Villages will show you that old people are very sexually active.
Also, when you're on the floor and you have a husband and wife that share a room, or the husband comes in to see his wife, you have to respect them.
Correct. That is correct. Yeah.
And it don't matter whether she's screaming or not.
Well, it does. We report that. We absolutely report that. Yes. And again, that's we have to have consent. So if the wife is screaming, that's something that's going to have to be addressed by the nurse and the entire ethics team. Yeah, that there's going to be a whole lot more to that. So if we notice it, we report it. Gastrointestinal system, food slows down, doesn't go through the system very well at all. So when we eat, the food stays in the stomach a whole lot longer. We don't get as hungry. Because everything's slowed down, tend to be at risk for constipation, very common. This is why we track bowel movements of our patients. Diminished nutrient absorption. But the last one there I want to talk about, decreased hunger and thirst reflexes. A lot of times as we age, we just don't get very hungry. Remember, smell and taste are affected. So you may have to work pretty hard to get your patients to eat. You also will probably have to work pretty hard to get them to drink, because that thirst reflex gets affected. Right now, when you get thirsty, you reach over and take a drink. You know, you don't even really think about it. You just grab your cup and take a drink when you're thirsty. As you age, if that thirst reflex goes away, you can become dehydrated and not even realize it. So a big part of what we do is encourage people to drink. Every time you walk in a room, would you like something to drink? Have you had your water yet? Here, take a drink for me. And that will help prevent dehydration. Dehydration leads to constipation and lots of other issues as well. And then we have the musculoskeletal system. This is bones, muscles. Your bones get less dense, so if you fall, more likely to break something. Muscles get weaker, so you're more likely to fall. So this is why as we get older, falls become really common. You can also have arthritis, which is an inflammation of the joints, and that can make everyday activities super, super painful. Instability and coordination is very, very common as we age. And then the lymphatic system, this affects the fluid balance in your body. That's what your lymph system does. But it also plays a big role in your immunity, your immune system. So if you don't have a very good immune system, you are at risk. Now, remember, you're in a place that has a lot of pathogens and you are at risk because your immune system is not working properly. So this just goes right back to what we were talking about with gloves. We have to remember who is at risk here. Any questions on body systems? All right, we're going to review the skills that we've learned so far. When we are taking a pulse is a measurement of how many times the heart beat. It's always reported over 1 minute, but how long you count will depend on the care plan, how long the care plan tells us to count. Normals between 60 and 100. We're going to use our fingertips, not the flat area of our fingers, and we never use the thumb. Your thumb has an artery. The radial pulse is located at the very top of the wrist, the thumb side of the wrist, at the bend, not way down here. It's where the lines are. We're going to say start and stop. So the evaluators start and stop when we do. In Florida, we'll count with 2 evaluators, and this is a documentation skill. We learned how to dress a resident. We're going to ask them what they want to wear. We're going to get the clothing before we undress them. We're going to lift from below, supporting all joints. We'll move slowly and smoothly. We're going to undress the strong arm first and dress the weak arm first, being careful not to overextend or force movement. When we leave, the patient needs to look good. So adjust the clothing. Make sure it's all snapped appropriately. The pants are over the hips. The toe seams are across the toes, not all cattywampus or something. Call light goes in the stronger hand, and anything that we took off of the patient goes in the hamper, not on the floor. Hand and nail care. This is a mini mani on one hand. That's all it is. We're going to soak the hand, wash the hand, rinse the hand, dry the hand, clean under the nails with an orange stick, wiping it off in between nails. File the rough edges with an emery board in one direction toward the center. Apply lotion last and wipe off the lotion with a towel or something so that we don't leave lotion on the surface of the skin. Making an occupied bed. The patient will be on their side while we're making the bed. We're going to make the bed a half at a time. Clean rolls toward me. Dirty rolls away. That's how we change the sheet underneath the patient. We remain behind the patient's behind. Remember, anytime we turn a patient, we always turn them away from us. We're going to smooth any wrinkles. We don't want wrinkles on the bed. We're going to make hospital corners. Loosen the sheet over the toes and replace the pillowcase with the opening facing away from the door. Range of motion, we've learned 2 of them so far. We're going to lift extremities from below with a flat palm, 2 points of support. We'll move slowly and smoothly all the way back to start. Otherwise, it's not a full range of motion. Flexion extension is up, down. Abduction, adduction is side to side. And rotation is around. So look at everything you've learned. We're going to move on now. So page 138 is where we're going to start today with side lying position. If you look down the side of the screen here, you'll see all of the principles involved in this skill. You can see them all spelled out here. And we know most of what we already need to know for the test, for this skill. I've got a video on this, short version of the steps here. Down here, you'll see testing information. Somebody with your level of experience should be able to do this within 8 minutes. We're turning somebody on their side, using pillows to prop them there. That's all we're doing. You should be able to do that within 8 minutes. This is a live testing student, so you'll be doing this on another person, and that person will be laying in bed. So we talked about scoot and roll on Monday, and we learned on Monday that you're not going to have side rails in all settings, and we can't rely on side rails to keep our patients safe. But we're going to talk a little bit more about this and the role that side rails play today. Page 139 has our care plan at the top of the page. It tells us to position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. It does not say your patient is immobile. It says they're unable to assist with turning. Do you remember on day one, I told you it's care plan, the whole care plan, and nothing but the care plan, right? Well, a lot of people look at this and they automatically think, oh, the patient must be immobile. Does it say they're immobile? Don't read into this. Don't put something in that's not there. It says they can't turn on their own. They can scoot towards you, though. So for the test, we're just going to ask them, scoot toward me. Because it says they can't turn. Doesn't say they can't scoot. But if they can't scoot, the care plan would tell us how we're supposed to move the patient in bed. A draw sheet, which is a flat sheet under the patient like a sling that we can pull their body weight toward us. A slide sheet, which is a super slippery piece of fabric that we put under to pull the patient toward us. You can move them in segments, their head and shoulders, their torso, their hips, and their legs. Lots of different ways to move a patient, but we don't need any of those. You can just ask the patient to scoot toward you. Remember, every patient's going to be a little bit different. That's why we need these care plans to tell us what to do with this patient. Down here are our supplies. Not very many supplies for this one. We need a barrier to have a clean place to put our clean supplies. We're going to need 3 pillows with pillowcases and a blanket because we're going to turn this patient and I'm going to put pillows behind their back, between their legs, under their arm. If that sheet is there, it's going to really affect my ability to put these pillows where they need to go. So I want to get that sheet moved out of the way, but we can't have an uncovered patient laying in bed. So we will use a privacy blanket for this. So let's talk about restraints a little bit more. When you are a baby and mom brings you home from the hospital, mom puts you into a crib, something with sides on it, so you don't accidentally roll and fall. But at some point, you get big enough and strong enough that that crib doesn't keep you in the crib anymore. What do babies do or children do once they are able to stand up? What do they do in the crib? They climb out. So now they're falling from this high rather than this high. That increases the risk of injury. So mom doesn't keep you in a crib. She moves you into a toddler bed. Bed super near the floor. And your body learns how to sleep in that bed. Make sense? Like you guys don't go home and sleep in a crib anymore, do you? So we have to understand that when a person, an individual, is old enough to determine where they want to be, high sides don't keep them there. If they want to get out, they will climb. So if we put a patient into a bed and put high sides on it, is that going to keep your patient in the bed if they don't want to be there? No. And in fact, what we did was make the fall much higher, which increases the risk of injury. This is why side rails are considered a restraint and they require a doctor's order. Now, some people are going to go, well, wait. What if the patient is at risk of falling? What if they request it? What if they want side rails? Doesn't matter. Patient can want all day long. We have to have a doctor's order. We don't get to make that call. Now, the reason for that is we can't trust healthcare workers. We can't trust you. Way too many healthcare workers throughout history have put their patients in a bed, put all the side rails up to keep them there, and then went to the break room and played a couple rounds of poker. If they got a particularly troublesome patient, they give them some Benadryl, knock them out. We can't trust you. So we have to have a checks and balances system. And that's why we need a doctor's order. We need somebody in authority that can verify that, yes, side rails are indicated for this patient. Because otherwise, all you have to say is, well, she asked for it. I just put the side rails up because she asked for it. We can't trust you. Board of Nursing takes this extremely seriously. If you are caught with side rails up and no doctor's order, you will be charged with false imprisonment. That is a legal charge. That's how serious they take this. Remember that positioning rails or half rails are not side rails. Half rails just help the patient move around in bed, something that they can hold on to, but it doesn't restrict the ability of the legs to swing out and get out of bed. But if we put that one up, it becomes a side rail. In hospitals, the big hospital beds, most of them don't even have side rails, the bottom side rails on the beds. They're not even there anymore. If we get an order for side rails, maintenance has to come up and put the side rails on the bed. Instead, what they do is they hire special people and they have them sit at the side of the bed for the whole shift. You become the side rail. If the patient tries to get up, you let the nurse know, hey, patient's trying to get up. If it's something that you can handle, if they're just trying to get some water, give them a cup of water. Make sense? These are called patient safety attendants, also called sitters, requires no medical training at all, and all of you are eligible for this position right now. If you want to work at a hospital, this is a great way to get your foot in the door while you're in training. Just look on the website for your specific hospital you want to work at. Look for an opening for a patient safety attendant and apply. Let them know when you go to the interview that you're in a CNA program. Good? So now let's talk about immobile patients. I said that this patient, according to the care plan, is not immobile. We didn't create that problem for the patient. But we do have to talk about what happens when a patient is immobile. Immobile means not able to move on their own. Now, if somebody is immobile, they're going to need some very specific, specialized care because immobility is going to affect every body system, everyone. With your nervous system, immobility can actually cause a slowing down of neurological impulses. Cardiovascular system, your blood is going to kind of stagnate. It doesn't move as well. So your heart is going to have a harder time pumping. Your lungs are going to have a harder time inflating because you've got gravity to work against. Your muscles and your bones are going to deteriorate. Your digestive system is going to radically slow down. Every body system is affected when you are immobile. So we have to put some things in place to help mitigate some of these risks. So if somebody is immobile, they're going to need assistance for all ADLs. We're doing everything because they're not able to move on their own. So this is going to slow digestion, reduce lung volume, decrease bone density, cause muscle atrophy, decreased immune response, and affects cognitive function. But one of the biggest organs that's affected is the skin. And I want to show you how the skin is affected. So the best way for me to do this is through an experiment. I want you to take one of your hands and put it underneath your leg. So between your leg and the chair. Go ahead and do that for me. I'm going to ask you to keep it there for 2 minutes. You're going to want to pull it out. I'm going to ask you not to. Just sit on one of your hands for about the next 2 minutes. I'll tell you when to pull it out. Now, the reason that we want to do this experiment is to figure out what pressure points mean. So a pressure point is any part of the body where the bone is going to press into the muscle and the skin against a harder surface. And this creates a pressure point. So the back of our head, our shoulder blades, our lower back, our elbows, the backs of our thighs, the backs of our calves, and our heels are all common pressure points. And these are areas you're going to see the biggest skin breakdowns when your patient is immobile. And what happens here is because of gravity. We have a bone, which is heavy, and that bone is going to press down into the muscle. That muscle is going to press into the fat. That fat's going to press into the skin. And it just pancakes or compresses all of this. Well, unfortunately, in the skin are all these blood vessels. So we press down on those blood vessels because of gravity pushing all of this weight down. And it crimps off those blood vessels. What do you think happens to tissue when it doesn't get good blood flow? What do you think happens to that tissue? Okay, it dies. Any tissue without oxygenated blood will die. So when we have all of this weight pressing down, squishing down on those blood vessels, it can actually cause that skin to die. And dead skin doesn't stay together. It separates, and this is called a bed sore or pressure sore. Now, this is further aggravated by the presence of wrinkles. If there's wrinkles on the sheet and all of this body weight is pressing down onto the wrinkles, well, now we've got an additional area of pressure pressing up because there's a difference in height. So what does this do? Well, it causes these areas that aren't getting good blood flow to separate and causes a sore, a pressure sore. Now, you're probably getting a little bit uncomfortable. You want to pull your hand out. So let's go ahead and do that. Go ahead and pull your hand out and take a look at it. Look closely. Do you have color changes? Do you have color changes? Look really closely. Can you see the pattern of your clothing or the chair imprinted on your skin? Can you see that? That was only 2 minutes. And you're healthy. 2 minutes, and you already have imprinting into the skin. What do you think would happen if we left your hand there for 12 hours? If 2 minutes imprinted on your skin, what would happen if we left your hand there for 12 hours? Those lines are going to get deeper and deeper and deeper and eventually cut into your skin. It only takes about 20 minutes for a bed sore to form in the right conditions. For most people, it takes a little bit longer than that. But if we don't move a patient that can't move themselves, that's exactly what's happening. Their body weight is pressing down on these areas, and it's going to cut off circulation. So if you have color changes or pattern imprints after 2 minutes, we have to think about what this means for our patients. This is why when you're sleeping, you change position all the time. You don't go to sleep and wake up in the exact same position that you went to sleep in. You turn, you move, you stretch, you flip, you flop, you do all kinds of things while you're sleeping. And the whole reason for that is to release the pressure in one area and put it somewhere else. And then you turn a little bit later and that releases the pressure from that area and puts it somewhere else. And this is just to ensure that all of the areas of your body are getting good blood flow while you're sleeping. You do this in class as well. You guys are sitting on hard chairs. It's not comfortable. You don't sit still. You're moving. You're jiggling your leg. You're changing position. You're doing all kinds of things. And all of that is because of this pressure dynamic. You're not supposed to sit still. Somebody should tell kindergarten teachers that. You're not supposed to sit still. Bad for the muscles. You're supposed to move around. And that just ensures we get good blood flow to those areas. But if we have a patient who's immobile and can't do this on their own, we are going to turn them every 2 hours around the clock. Around the clock. We don't leave them there for 12 hours and let them sleep, because that skin, when you do move them, will have a huge sore on it. So at 2 a.m., we're waking them up and turning them over. At 4 a.m., we're waking them up. At 6 a.m., we're waking them up. Don't do them any favors and let them sleep through the night, because they may not ever be able to sleep again with a bed sore. They're extremely painful because most of them go right down to the nerve or beyond. Some of them go into the bone. It's horrible. Worst, to me, this is the worst part. Nursing homes have a pretty good handle on this. Nursing homes turn their patients every 2 hours around the clock. They're pretty good at this because they know. Do you know the one place that you're most at risk for a bed sore? Say it. Hospitals. Yep. You would think that's the one place that you would absolutely not get a bed sore at all. But the hospital is statistically the worst place for bed sore formation. So if you go to a hospital and there's nothing on your care plan about turning a patient every 2 hours, you should probably be bringing that to your nurse's attention. Hey, there's nothing on the care plan. Should we be turning this patient? They don't turn on their own. We don't want bed sores. And your nurse is probably going to go, oh, yeah, this should be on there. Remember that not all nurses are great nurses. Not all nurses write great care plans. We have to work as a team. It is not you versus the nurse. It's us together versus whatever's trying to kill the patient. So if you notice a gap, bring it up. Remember that observation thing? So when we're turning a patient, this is a turning clock. You can make these for your patient's rooms. Perfectly okay. This is well within the CNA scope of practice. And it just means that, at this time, this is where your patient should be. So if I walk in the patient's room at 1 o'clock in the afternoon, they should be on their right side. I can look at the turning clock, look at the patient, and make sure that those two match. Turning clocks keep everybody on the same page. But when we're doing this, we're going to go from their back to their right side. 2 hours later, back to their back. 2 hours later, left side. 2 hours later, back to their back. Right, back, left, back, right, back, left, back, every 2 hours around the clock, never on their stomach. Do not put an immobile patient on their stomach unless that care plan specifically tells you to. Remember, gravity's at play here. And all of that weight along your back, pressing down, gravity pulls stuff down. Pressing down can keep your lungs from being able to inflate. You can accidentally suffocate your patient who's immobile by putting them on their stomach. Do not put an immobile patient on their stomach unless the care plan specifically tells you to. Now, we did find that with COVID, when we had patients on ventilators, when we put them on their stomach, they did much better because the secretions went to the front of the lungs, which was less likely to impede oxygenation. So that was good. So we did find that patients on ventilators with COVID tended to do better on their stomach. So that care plan would say to make sure you're changing the patient's position and prone or on their stomach is appropriate. This is why we need a different care plan for every patient. Good? Bless you. So remember that when we turn patients, they must always be in the middle of the bed. So if I'm going to turn somebody, I've got to scoot them toward me first, then turn them away from me. So after the turn, they end up in the middle of the bed. Remember, scoot and roll is super important. We always roll somebody facing away from us on their side near the edge of the bed. For the test, we can just ask them, hey, scoot toward me, would you? And then we'll turn them on their side. But turning somebody who cannot turn themselves requires an additional step. And that means that we're going to have to position their body for the turn. Since we're the one doing the turn, we have to position their body for the turn. Now, this is what we were talking about earlier. If your patient can't scoot towards you, you can use a draw sheet, which is just a flat sheet under the patient. We use it as a sling. We just pull them toward us. That's a draw sheet. This is our extra step. Now, if she can roll on her own, if she can move on her own, I'm just going to ask her, hey, turn on your side. But if she can't, if I'm the one that has to do it, we have to prep the patient properly. I used to work with bariatric patients. These are patients that are 500, 600, 700 pounds. This is way back 25 years ago. Weight loss surgery was a thing, but not that common, and you had to wait forever to be able to get it done. So a lot of these patients were bedbound before the surgery, and we would go in and take care of them and get them cleaned up and things like that. Well, this was one of the things that I had to do, was turn a patient that's 600, 700, 800 pounds by myself. And with this technique, you can do it easily. It's all about prepping. You got to prep the patient. So if you remember, we always have to turn a patient facing away from us. So we scoot them toward us, so they're laying on their back close to the edge of the bed here, and I'm going to roll her facing away from me. And it's important that you understand that, because how we set the patient up is going to depend on that fact. We're going to turn the patient away from us. So the furthest arm away from me is going to go above her head. I don't want that arm by her side, because when I turn her on her side, she's going to be laying on that arm, which is going to squish all of those blood vessels. We need that arm out of the way. So that arm is going to go above the head. The closest arm to me, like if I'm standing here, the closest arm to me is going to cross the chest. So if I'm going to turn the patient on the left side, which is what our care plan says, this arm goes up, this arm crosses the chest. And we're going to roll them to their left. If I were to roll the patient on the right side, I would stand over here, this arm goes up, and this arm crosses over, and we roll them that way. That way they're not laying on that arm after the turn. Good? But now this is the part that really helps make the turn easy. The closest leg to me is going to bend at the knee with the foot flat on the bed. The furthest leg from me is going to angle outward. So I'm going to bend the knee and angle it outward. Now, when I do that, right, patient's arm is up, arm is crossed, leg is bent, leg is angled. They turn. Super easy. You can turn somebody 3 times your body weight without any issues at all, as long as you prep them right. Now, after the turn, though, we got to do something to keep them in place, because if we don't, gravity is just going to pull them right back onto their back, and that's not going to do us any good. So we've got to have a way of keeping them on their side. We also don't want those bones to rub together, like with the knees. If you've got one knee on top of the other, those bones are going to rub together, and that compresses blood vessels. So we're going to put a pillow in between those legs to keep them separated. We're going to put a pillow behind the back to keep them on their side. We're going to put a pillow underneath that top arm to keep it in good alignment. And then I've got adjust the pillow behind their back or behind their head to keep it under the head and neck and not the shoulder. So we're going to add 3 pillows to the bed and adjust the one that's on the bed for this skill. If you understand this, this is what they're testing you on for the test.
I understand it, but where would your hands be? Let's say when you love a patient, where would you get?
One on the shoulder, one on the hip. Just like that. One on the shoulder. Now, if I've got somebody that's really long, I'm short. But if I've got somebody that's really long, hand on the shoulder and hand more between the hip and the thigh area right here. Because you want to distribute the force kind of equally along the body.
So they're not using a draw sheet or pull sheet.
No, we have to know how to do this without a draw sheet for the test. And it's all about positioning that patient, because if you just use a draw sheet and log roll that patient, they're on their arm. So that's an additional area of pressure. They're also straight, which is not comfortable. When we get on our side, we generally tend to bend our legs, our knees, to relieve that pressure on the lower back and put us in a more comfortable position. So using a draw sheet to just log roll somebody, they're not in the right position after the roll, which is why we don't use that on the test. Good? Questions so far?
How about if, let's just say they have an injury on their shoulder when you're trying to move them? Will it say something different on the care plan? Hey, injury right here. Try to learn how to
Right.
position them differently.
Right. If there's any accommodations that need to be made for that specific patient, it would be mentioned on the care plan. For instance, let me give you for instance. Let's say that we have turned the patient onto their right side, but they just had shoulder surgery. Now, that's going to be a problem because I don't want all of that body weight on that right shoulder after the turn. So the care plan may say to wedge under the left side. So we kind of get them a little bit on that right side, but not a full turn, right? So we would wedge so they're not completely on their side because I don't want that pressure on that shoulder.
Okay, how about they're perfectly fine and we move them and they're like, oh, well, this hurts. Do we just tell the nurse, hey?
Right. Try to reposition, get them comfortable, obviously, and then go tell the nurse, hey, patient's complaining of pain in that right shoulder after I turned them. And then let the nurse go take a look. Maybe it's just they've been laying in bed too long. Have you ever laid in bed for a long time and got sore? It could just be that. Perfectly normal. It could also be that, they're developing a bone spur somewhere. I mean, I don't know. I got to assess to figure out what's going on. So by you telling me that the patient had a complaint, it gives me an opportunity to look into it a little bit further. All right, so when we position them for turning, the farthest arm goes up, closest arm crosses, closest knee is bent, furthest knee is angled. We'll roll the patient to the middle of the bed, making sure that upper leg is not directly over the lower leg. Remember, we don't want those knees one on top of the other. We're going to put a pillow behind the back in a roll. We'll put a pillow between the legs, specifically between the legs or the knees and ankles. We'll put a pillow under that top arm to get it in a neutral position. And we'll adjust the pillow under the head. When we do this, the call light goes in the lower hand. And that's because if I were to turn this, now she doesn't turn well, she's a mannequin, right? But if I were to turn this patient and I've got her adjusted, this arm goes up, this arm crosses, this knee's bent, that knee's angled, and I roll her on her side. So if I've got her on her side, if I try to put this call light in her top hand, do you see where that call light runs? Right over her neck. So we don't do that. The call light has to be in the bottom hand where the cord is on the bed, not over the patient. Make sense? So call light goes in the bottom hand. So let's look at this care plan one more time. Position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. Doesn't say they're immobile, just unable to assist with turning. All right, Jake, go ahead and put this video on. I'm going to show you the video because it has really good close-ups of those pillows. I want you to pay attention to how the patient is positioned and the pillow placement. That's good.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to turn you onto your left side. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay.
I'll start gathering your supplies. We'll start with a barrier, which I'll place on the table to provide a clean area to place my supplies. And I'll get 3 pillows from clean supply cabinet, being careful not to allow them to touch my uniform. Mr. Jones, I'm going to place this blanket over you, and this will help keep you warm and protect your privacy while we do this skill. Once I have the blanket in place, then I'll pull the sheet down underneath the blanket, making sure the patient remains covered at all times. Okay, Mr. Jones, if I could have you scoot toward me, please. I'm going to place your furthest arm above your head and cross your closest arm over your chest. I'm going to bend the closest knee and put the foot flat on the bed. And I'm going to angle the furthest knee out a little bit. Okay, now I'm going to turn you onto your side. 1, 2, 3. Okay, I'm going to take the first pillow and put it in an angle up against the back, and I'm going to tuck this top edge underneath the patient by pushing down on the pillow and under his back. This edge will roll up, and then it too will be pushed down and under, forming a roll along the back. Okay, now I'm going to position a pillow between the 2 legs by lifting the top leg and laying the pillow lengthwise between the 2 legs, specifically between the knees and the ankles, to prevent those bony areas from rubbing together. This pillow is going to be placed underneath the upper arm. This will help keep the arm in a neutral position as the patient remains on their side. And then I'm going to adjust the pillow underneath the head to make sure that it's not under the shoulder and it remains only under the head and the neck. And then move the arm to a more comfortable position. Is that comfortable, Mr. Jones?
Yes.
Okay, I'm going to place the call light directly in your hand. Are you comfortable?
Yes.
Can I get you anything else while I'm here?
No.
Okay, let me pull your sheet up. And remove the privacy blanket. Being careful not to dislodge all of those pillows as I do so. I'll roll the privacy blanket up and place it in dirty linen. The barrier will be thrown away. Mr. Jones. I'm going to open your privacy curtain now. Is there anything else I can get for you while I'm here?
No, thank you.
Okay, I'll see you soon. Let me go wash my hands. After washing my hands, I'll review all the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay, any questions on that one? Any questions?
Pillow in the back.
What's that?
When you folded the pillow in the back, so you put half of it on the resident, and then you tuck it underneath.
Right.
Okay, and you fold the other one, or the other side of it.
Right. So if where's
Fold it down, or
where's my little guy here? All right. If this is my patient, okay. Give you a visual. This is my patient laying on her side, right? So I put the pillow up at kind of an angle like this. I'm going to tuck this edge of the pillow underneath the patient here. So I'm going to push it all the way down and then under the patient like that. You can't just push it you push it into the patient. They're in the way. So you have to push it down and then under. And the beds are really springy, right? You saw that when you were in the bed. The mattresses are really springy specifically. So hospital mattresses are different than regular mattresses. It's specifically to allow us to get under patients. Then this edge here is going to roll up, and we're going to do the same thing with it. Push it down and forward. So the action is exactly the same for both edges. And then it keeps the patient from rolling backwards. Good. Questions? I'm trying to go through these to get us a little bit of practice time today. Okay. So I'm going to try to kind of get through these so you have a little bit of practice time today. But if not, if we run out of time, Monday, you're going to have about 45 minutes of practice. Wednesday, you're going to have about an hour to an hour and a half of practice. The following Monday, you have about 2 hours of practice in class time. Okay. All right, so let's learn foot care. This is on page 118. And the good news is there's nothing new to learn here. Nothing new to learn on how to do foot care. You guys already know how to do foot care. It's hand and nail care, a little bit lower. But we don't do anything with toenails. You know, remember with hand and nail care, we cleaned under the nails and then filed the rough edges? We don't do that with toenails. Not our job. We just look and we notice if there's anything that needs to be addressed, because we actually have special doctors that come to facilities to do those types of things. They're called podiatrists, and their whole job is to take care of feet. So we do foot care and we look for problems. If we find any, we let the nurse know. The nurse puts the patient on a podiatry list, and when the podiatrist comes in, he sees those patients. If you don't do foot care or you don't relay a problem to the nurse, the patient will never get seen. Now, let me tell you why you're doing foot care, guys. It is not to clean the foot. It's really not. Feet get cleaned in the shower. That's not why we're doing this. We're doing this because a lot of times patients have foot injuries they're not aware of. I'm going to explain how that happens in a minute. But a lot of times patients have foot injuries and things that they're not aware of because as we age, we're less bendy. So you guys can all look at the bottom of your feet. I mean, you're bendy. Right? You can pull your foot up to your knee and you can take a look at the bottom and you can see if there's any problems. You also have a great nervous system that's telling you what's going on all over your body. But as we age, we get less bendy and our nervous system isn't working all that well. So we can have injuries that we don't even know are there. And that's why foot care needs to be done. Now, years and years and years ago, we told CNAs, hey, you need to look at every patient's feet every shift. Just make sure you take a quick peek at the feet. And this is what the CNAs did. My gosh, Miss Jones, they want me to look at your feet now. Like I don't have enough to do. Yeah, you got feet. I don't know why I have to do that. I mean, that's what they did. Yeah, the feet are there. That's not what we needed you to do. We needed you to look at the feet to see if there's any problems. So, since CNAs didn't do what we needed them to do, we created a skill for them. Because we figure if you soak a foot and wash a foot and rinse a foot and dry a foot and lotion a foot, at some point in there, you'll actually look at the foot. That is why you're doing this. You are doing this skill because the CNAs that came before you were lazy.
And if they do have a foot injury, like an open wound, do we still do foot care or just tell the nurse so we can get orders from her to see?
Depends on where you're at. Okay. If you're in a location that has a nurse readily accessible, stop and go get the nurse. And it's better. Let me kind of explain this. If I'm the nurse here, this is our place. I'm the nurse here. You guys are all my CNAs. You're doing foot care. You notice an open wound, but you do foot care anyway. You get their sock and shoe on. You take them to the activity room. And sometime today you come and let me know, hey, there was a wound on the foot, the right foot. I'm going to tell you, go take him back to his room, take the sock and shoe off so I can take a look at it. Right? So that just doubled your work. If you come get me right away and say, hey, I'm doing foot care, there's a wound. You want to look at it before I get it, buttoned back up? I'm going to say, yes, hold up. I'm going to stop what I'm doing and go look at that wound. And then I'll be able to tell you, yeah, go ahead, finish up foot care, it's fine. Or I don't want soap anywhere near that thing. Stop. So it depends on the setting that you're in if a nurse is readily accessible. If you're working in assisted living facilities, you may not have a nurse on staff. Nurse might have to be consulted by phone. If you're working in home care, there is no nurse in the house. If you're working in a nursing home and your nurse that you report to is on break, that could be an issue, right? So it depends on the setting that you're in. My own personal recommendation for the CNAs that I work with is if you find a wound, don't put soap in it, come get me. Because soap can irritate a wound. Yeah, so I don't really want you around that wound. I'd rather take a look at it. But I don't want that patient to be sitting there for 30 minutes while I'm on lunch break with, a wide open wound and nothing covering it either. So it gets a little bit tricky there. So handle it the way your nurse that you're working with wants you to handle it. Does that make sense? Not all nurses are going to think the same way. All right. So nothing new to learn here as far as principles. Yay. But there are some things that we have to learn about foot care itself. So if we look at the care plan at the top of the page, it says provide foot care to 1 foot. What if they have 2? Care plan. Care plan says 1. We're only doing 1. And the care plan actually is letting you pick which one. For the test. They don't care. As long as you demonstrate it, they're good. So it just says 1 foot. Using soap and water. So it's going to tell us what to use. It says the resident is sitting in a chair and their sock and shoes should be replaced at the end of the skill. The reason that this is in the care plan is because this is a live patient skill. One of you guys may be a patient for this skill. That means somebody is really going to be doing foot care for real on you during the test. I know it's uncomfortable. I get it. Just go to your happy place. Let it be done. But because it's a live person skill, you guys are the patients. You probably don't have a clean set of socks in your pocket. You probably only have the socks you wore to the testing center. So during the test, they're going to wash their foot, and then they're going to have to put that sock and shoe back on. And normally we wouldn't do that. Normally a clean foot gets clean socks. But for the test, there are no clean socks. You guys understand that? That's why this care plan says put their sock and shoe back on. Okay? That sentence is all about the test, not clinical life. Supplies are at the bottom of the screen there. You'll need a barrier to put on the floor this time, not on the table. We're going to use a bath basin, soap, lotion, 1 towel, 2 washcloths, the patient's socks and shoes, and we need some gloves. Now, we're not using gloves because it's feet, and feet are gross. I get it, but that's not why we're doing that. We're going to use gloves for this because there's a potential exposure to open skin. The whole reason we're there is to look for open skin. We're not sure if there's any or not. So, because there's a potential, it's going to require gloves. Make sense? All right, so this is just like hand and nail care, except we don't do anything with nails. We're going to support the foot just like we supported the hand. We're going to soak the foot in water just like we soaked the hand. We're going to wash, rinse, and dry just like we did the hand. We're going to make sure that the foot is on a towel just like we did with the hand. Very, very similar here. We're not going to do anything with nails other than look at them. And lotion, with the hand, we put lotion everywhere. With the feet, no lotion between the toes. Lotion holds in moisture. And remember, the toes are already warm, and we have them in socks and shoes, so it's dark. And when you hold in moisture, we get warm, dark, and moist, which is not good for pathogen growth. Actually, it's excellent for pathogen growth, not good for us. So if we put lotion between the toes, it actually can lead to fungal infections, athlete's foot. We are going to inspect all surfaces for wounds, sores, rashes, red areas, anything that we see that doesn't look right. Let the nurse know. Don't put the bare feet on the floor. Make sure bare feet are always on the barrier, or better yet, on a towel on the barrier. We'll replace the sock, removing all wrinkles, and apply the shoe over the sock and secure it appropriately. I don't know why. It was passed on to me a couple of months ago that during the test, CNAs doing foot care or candidates doing foot care are not putting the shoe back on. Or if they're putting the shoe on, they're not tying it. They're not securing it. That's a trip hazard. So you're going to treat the test just like it's a real setting. You wouldn't leave a patient with shoelaces that they could trip over or without a shoe at all. Make sure that you keep in mind that this is like a clinical setting. I don't want you to think about it as a test. I don't want you to cut corners. Do for the test what you would do in a clinical setting. Okay, good. All right, I told you there's nothing new to learn here, and that is true regarding foot care. But we do have to learn a little bit about diabetes. Yeah, we have to learn a little bit about diabetes. Here is, okay. All right, so when it comes to diabetes, we have to understand a little bit about metabolism and glucose use and storage in the body. So this is a 5th grade version of diabetes. I'm super simplifying it. People that make their living off of education with diabetes, I mean, this is like you go to school for 2 years just to learn nothing about nothing but diabetes. It's extremely complex. I'm really simplifying this, so keep that in mind. I don't want any comments telling, that I missed some stuff with diabetes. This is CNA diabetes, okay? I get all kinds of comments sometimes. All right. Every cell in your body, every cell needs fuel to run. every cell. Now, the preferred fuel is glucose. That's what your cells run on. And that's a good thing. In order to get glucose, for the cells to function properly, we eat carbs. Carbs break down into glucose. Now, carbs in our society get a bad rap. Carbs are not bad. They're not bad guys. Carbs in excess are bad. But carbs themselves, not bad as long as you're maintaining a good carbohydrate to protein ratio. We're going to get into that in just a minute. But every carb you eat in the body is going to break down into sugar. That's what your body does with it. It breaks carbohydrates down into its component sugars, and it puts those sugars into the bloodstream. Now, when the sugar gets into the bloodstream, it can't enter the cells. We took in carbohydrates, it broke down into sugar. That's great. Sugar's in your bloodstream, but it cannot get into the cells. Not by itself. That cell is locked. What you need is a key to open the cell so the sugar can go in. And that key is actually called insulin. It's produced in your body by your pancreas. This is a hormone, endocrine system. We talked about that earlier today. So when you eat carbs, it breaks down into sugar. It goes into your bloodstream. Your pancreas is told, hey, we need some keys. So your pancreas pushes out some insulin, and the insulin then unlocks the cell. The sugar is able to enter the cell, and the cell is now fueled. So you guys understand that process? No insulin, sugar doesn't get into the cell. Good? 5th grade. This is what happens when the insulin does not unlock the cell. So we have a cell that's starving, and it's saying, hey, I'm hungry, I'm starving, do something, brain. So the brain triggers a craving, usually for something sweet, a carbohydrate. So the patient eats, and we get blood or sugar in the bloodstream. If the pancreas isn't producing keys, that sugar has nowhere to go. Nowhere to go. It can't go into the cell without a key. It can't be peed out. It has nowhere to go. So it just circulates in the bloodstream, round and round and round and round and round and round and round. So blood sugar levels increase. That tells us that there's sugar available to the cells, but it's not getting into the cell. There's nothing to unlock that door. Make sense? So let's talk about all of this sugar. Well, with normal metabolism, what happens when we've got all of this excess sugar, even if we have good insulin levels and we've fully stocked our cells and we have excess sugar running around. Remember I said carbs in excess are bad? Right? So we got all this sugar in the bloodstream that we got to do something with. Your body has a method of storing it. It actually takes these sugar molecules and puts it into a box, tapes the box shut. That box is now called glycogen. That box is now called glycogen. And it takes that box of glycogen and it shoves it into a storage unit for later. That storage unit is called a fat cell. So excess sugar that is not used by the cells is going to be converted into glycogen and stored in your fat cells. Now, if you ever get to a point in your life that you're not taking in enough sugar and your cells get hungry, we can open up those storage units, unpack the boxes, and use the glycogen. So the system works really well, as long as we're using what we're storing. But what ends up happening, especially in American diets, is that we store all of this glycogen in our storage units, our fat cells, and we never go back and use it because we take in carbs the next day and the next day and the next day. So they're just kind of sitting there just waiting. And it's kind of like, if you've ever watched like Storage Wars, You know that show Storage Wars, where they open up these storage units and there's like shag carpet from the 1960s and nobody wants that. You know, it's like all the stuff in there is junk. Well, that's what happens to these fat cells after a while. That glycogen is just like, can't really be used. So this is why it's so hard to lose fat, because it's hard to use that glycogen when it's super old and nobody really wants it. It's icky now. So if we can't use the glycogen, we can't shrink the fat cells. Make sense? Good. Okay. Now, if we have all of this sugar in the bloodstream and none of it is getting into those cells are still starving. And they're ringing up the brain going, hey, I'm hungry. I'm starving. Can you do something here? So the brain is going to trigger a craving, usually for something sweet, a carbohydrate. Anybody know a diabetic patient? Anybody know somebody with diabetes? What do they crave? Sugar. Absolutely. Candy, donuts, bread. They want all the carbs. And it's because their cells are legitimately starving, dying. Those cells are dying for real. So when you have a diabetic patient that is craving sweet stuff, don't yell at them. They are responding to a very real emergency in their body. Now, the problem is the brain is not aware that whatever carbs they take in are still not going to be able to be used. The brain is just reacting to the cell saying, I'm starving. So eating those carbs isn't going to help your patient. It's not going to get rid of the craving. It's not going to fuel the cells. It serves no purpose other than to push more sugar into the bloodstream that we can't use. And remember, we can't get rid of sugar. You can't pee it out. So it's just going to circulate. Now, the good news is that there is a back door on our cells. And that back door is very small, not as efficient, but it does work. And it's opened not with insulin, but with protein. So if we have a diabetic patient who is getting a craving for carbohydrates, we know that their cells are dying. If you can get them to eat some protein with that carbohydrate, that protein will open the cell and allow some of that sugar in. So a half of a tuna fish sandwich. The bread is the carbs, the tuna is the protein. A slice of cheese and a couple slices of apple. Cheese is the protein, apple is the carbs. Graham crackers and peanut butter. Great diabetic snack. So you want to pair protein with carbohydrates if you can't get them to not eat that carb. Just try to work some protein in there with it. Good? Does that make sense? So I want to talk to you now about what happens in the body when we have all of this sugar circulating round and round and round with nowhere to go. And again, we have this whole gravity problem. Gravity really does a number on our bodies. It does a lot of really crazy things when our bodies aren't working right. When your bodies are working great, gravity is your friend. But when things start going wrong, gravity can play a big part in the effects of that disease. So this is what happens. Sugar is a crystal. Kind of looks like this. This is what sugar looks like magnified. See how it's all sharp and jagged edges and it's hard? Okay, have you ever had like a cupcake or a cake that's left out on the counter for a couple days? What happens to the frosting?
Gets hard.
Yes, it gets hard. It crystallizes. That's the term. It crystallizes. So the oil and the sugar kind of separate out and you get this hard crystal, right? It's the same thing that happens inside your arteries. The oil and the crystals separate out. So now we got these crystals and they're circulating round and round and round and round. Well, there's nowhere for them to go. They don't go into the fat cells because those are full. They don't go out through the bladder because we can't pee them out. So these sugar molecules just go round and round. They're sharp, round and round in the body. Eventually, they're going to coat the insides of your arteries. and they look like this on the insides of your arteries. And they're going to collect anything that happens to float by, like cholesterol. Cholesterol looks in your body like pizza cheese. Kind of floats through your bloodstream, looking like pizza cheese, acting like pizza cheese, stringy. And it's going to get all wound up in there. And that's going to reduce the space that blood has to travel through. But it doesn't stop there. Those sharp edges are also going to cut cells as they float by. So now we've got fewer cells taking oxygen where they need to go. We've got fewer immune cells being able to fight off pathogens. We've got fewer platelets to stop bleeding when it occurs. You see how that might be a problem? Now, when we are born, your arteries look like this. This is what your artery looks like when you are born. It is a great artery. I wish mine looked like this. Mine don't. And I'm going to explain to you how this process happens and how diabetes occurs in just a few minutes. But if we have an artery like this and we eat right and exercise, our arteries stay like this, but most people don't. So as we age, we start to get this little buildup. Remember I said pizza cheese, right? So we start to get this little buildup. Do you see how the walls are actually thicker on that one? You see that? The walls are kind of thicker. That means the inside of this hose is smaller than the inside of this hose. Do you remember we talked on Monday about blood pressure? And I said that blood pressure is the amount of pressure inside the hose when the heart beats, when the heart contracts. Well, if we have a smaller hose, that means the pressure inside is going to be higher. So this person is starting to develop high blood pressure. You see that? Now, if we don't change our ways and we really get some sugar crystals coating the inside of our arteries, and it's going to start collecting all of these cells and cholesterol that's floating by, we start to develop this. This is plaque on the inside of the arteries. And it's because our sugar molecules are not going where they need to go. They're settling on the inside of the arteries and catching everything that's floating by. So if we started to get high blood pressure here, imagine what our blood pressure looks like there. Now, if we don't treat this, if we don't address this, that's what the arteries are going to look like. The one thing I want you to remember out of this is when blood slows down or stops, it clots. When blood slows down or stops, it clots. This person is at risk of blood clots. When it happens in the brain, it's a stroke. When it happens in the small vessels of the heart, it's a heart attack. When it happens in the legs, it's a DVT. Blood clots are very common among diabetic patients. So they're at risk of strokes and heart attacks and other issues. Blood clots in the arms are less common, but they do happen. And the treatment would depend on where the clot is located, artery or vein. Does that make sense? This is bad. This is bad. Okay, so let's figure out how we got there first so we can figure out how to stop it. So let's talk about this real quick. A lot of people in America, in fact, they're now saying about 70% of Americans over the age of 65 will develop diabetes. And this is very concerning because, this, very concerning. So how do we get there? And a lot of patients say, well, I never had diabetes before. Why, now that I'm 70, did I all of a sudden get diabetes? And what they don't understand is diabetes did not start when you were 70. It started when you were 3. And this is why. American diets are horrible for this. Child gets up 6 o'clock in the morning. Mom's not really ready to be up and moving yet. So mom plops the kid down in front of the TV with a Pop-Tart. Mom lays on the couch and just kind of naps on and off while Bluey is playing until a more reasonable hour. Well, that Pop-Tart is carbohydrates. Carbohydrates break down into sugar. The sugar requires insulin to go into the cells to be used. Sound familiar? Mom finally gets up around 7:30 and gives the gives the child breakfast. Children aren't eating all bran. What kind of cereal do kids eat? Oh yeah, Captain Crunch, Fruity Pebbles, all the good stuff, Tricks, all the good stuff. Well, that is carbohydrates that break down into sugar that require the pancreas to produce insulin. Mid-morning snack. Mom's a good mom, so she gives the kids some fruit. Well, fruit is fructose, which is sugar, and it requires the pancreas to produce insulin. Lunch. National toddler lunch is chicken nuggets and mac and cheese. So chicken nuggets has a little bit of protein, but it still has a lot of carbs, especially if we're dipping it in ketchup, which has carbs. Mac and cheese, carbs. So we're using our pancreas to produce insulin. Afternoon snack, probably a little Debbie something, right? Some sort of sweet snack cake of some sort, cookie. Those are going to break down into sugar that requires your pancreas to produce insulin. Dinner, buttered spaghetti and a salad, but the kid's not going to eat the salad. The buttered spaghetti is carbs, which break down into sugar, making your pancreas produce insulin. And then, of course, we have to give dessert before they go to bed, which is something sweet that breaks down into sugar that makes your pancreas produce insulin. Now, this isn't limited to 3-year-olds. This is how the American diet is set up. We are carb heavy from a very early age. Very early age. So if we play this out over 65 years and we're making our pancreas work that hard for 65 years, at some point your pancreas is going to go, I'm out. I'm done. You've overused me. No more. And that's why we develop diabetes as an older adult, because we have plain misused our pancreas throughout our entire lifespan. And yeah, it kept up with it for 65 years. And then it decided, I'm done. So if you want to prevent that, watch your carbohydrate intake. Now. Don't make your pancreas work that hard. Good? Does that make sense? All right. So we have this buildup of gunk on the inside of our arteries because we have all this sugar running around and nowhere for it to go. But gravity on Earth is going to pull these heavy crystals downward. What is the lowest point of the upper body? What is the lowest point of the lower body? Feet. So because crystals are heavy and they're being pulled downward, diabetics are going to have problems on their hands and feet. Hand and nail care, foot care. That's why you do it. It's because your diabetic patients are at risk of injury through blood clots, through lack of oxygenated blood, through whatever mechanism. They're at risk, and it's up to us to find those problems. And the hands and feet are going to be the most at risk, but it gets worse. It gets worse. So these sugar molecules don't just coat the inside of the arteries. They also coat the nerves. Now, nerves are kind of like telephone wires. signals travel through the nerves. So if I have a wound on my foot, that signal has to travel through a nerve all the way up to my brain to say, hey, brain, we got a problem here. If that nerve is covered in sugar molecules, that signal is not going to be able to make its way through. So the foot knows there's a problem. It's telling the brain, hey, there's a problem, but the signal isn't getting there. And that's why a lot of our diabetic patients have a wound on the bottom of their foot and has no idea that that wound is even there. So many years ago, I was they're not called substitute nurses, but that's the best way for me to describe it. It's called an agency nurse. But you know how in school you had a substitute when your teacher couldn't show up, and basically they're just there to fill the spot? Well, that's what agency is. They're just kind of there to fill the spot. And we still do medications and treatments and assessments and things like that, but that's not really our patient. We don't know them that well. Well, I was an agency nurse. I was assigned to this facility. It had long-term care and rehab, and I was assigned to the rehab side and got my patient assignment. I'm going around doing my assessments, and I walked into this patient's room. We'll call him Henry. And as I walked in the room, Henry was laying in bed. He had this really small light right above his bed, and all the other lights were off. So as I walk in, I flip on the lights because I got to assess. And I said, hey, Henry. And he starts yelling right away, turn it off, turn it off, turn the light off. Okay, so I turned the light off. Walked up to the bed and I said, hey, I'm Patty. I'm your nurse today. Is there a reason we don't want the light on? You have a headache or something? And he says, no, I've got diabetic retinopathy and the bright lights hurt my eyes. I said, okay, cool, no problem. So we're having a conversation. I'm doing my assessment, trying to figure out, what this guy's got going on. And as I'm standing there, I'm catching an odor. Now, if you've ever smelled a wound, they're very distinctive. And I know this guy's got a wound somewhere. So I pull out my report sheet and I'm looking, and there's nothing on that report sheet about this guy having a wound. There's no wound care orders. There's nothing. So I tell him, hey, Henry, I need to take a look at you because I think you might have a wound brewing somewhere. Let me take a quick peek. He says, do what you got to do. Now, this guy was in his 50s, young, very gruff. All rough edges, nothing nice about him. And he turned over and let me take a look. And I looked at the tips of his ears, the back of his head, his shoulder blades, his lower back, all the way down, all the usual suspects. I'm not seeing a whole lot of anything. So I looked at his feet, and he's got those slipper socks on, the kind that have like the white dots on the bottom of them. He's got those slipper socks on. And I said, hey, Henry, I got to take your socks off and look at your feet real quick because I think that might be where our wound is. And he immediately barked out, no. Okay, there's my red flag. Because if he's telling me no, what did he tell the CNAs? And nobody reported it. Nobody reported it. So I have no idea how long this guy had gone with nobody looking at his feet. No idea. No idea. But I sweet talked him because you can always get further with patients by being nice than being mean. So I turned up the charm and I got him to agree to let me take his socks off. And I took the right sock off and it came off. Foot was flaky, needed to be washed, but it was okay. Tried to take the left sock off and it was stuck to the bottom of his foot. Oh, there's my problem. So I go get a basin of warm salt water. We call it normal saline. And I put the whole foot in it, sock and all, let him soak. Washed my hands, went and looked at some other patients, came back 10 minutes later, put my gloves on, and I tried to take the sock off. And it was really stuck to the bottom of the foot, even after soaking. But I managed to kind of pull at it and get this sock off. And looking at the bottom of his foot, he had an area probably about that big around. It was hard, black, dead tissue. Now, we're good in medicine. We can heal a lot of things, but dead is dead. We're not like Frankenstein level yet. We can't bring stuff back from the dead. This is dead tissue. So I know this guy's got a long road ahead of him. Not good. But as I did that, as I pulled back on the socks, something went flying past my head. And I looked down on the floor and it was one of these, not this one, but one of these. It was a flat, white, painted metal thumbtack. This had been in the bottom of his foot. Now, you might be thinking, how can somebody have a thumbtack in the bottom of his foot and not know it? This is how. That wound had not been found, and it was allowed to fester, and eventually it killed the tissue. About 9-10 months later, I get back to that facility. The guy had to have a below-the-knee amputation in his 50s. Now, the worst part of that story is it was 100% preventable. If that guy had had shoes on when he was walking, where would the thumbtack be? In his shoe. Now, I gave you a couple clues to this story. I told you that he asked the light to be turned off. That means that the room was dark. He said no when I told him I needed to look at his feet. That means he told the CNA no. All of these things mean that this wound could have been found a whole lot earlier. So first, we need to make sure that our patients have shoes on when they're walking to prevent injuries like this. But second, we need to make sure that if our patient is not letting us look at things, we're letting somebody know. Because this guy lost a leg over it. And it was completely preventable. That's horrible. We've got to do better than that. So you guys are really, really important in the nursing process. If you're not doing your job, the patient's the one that's going to suffer. Does that make sense? All right. So this is our last principle that we're going to learn, and we're not learning all of it today. But the first one there is super important. Super important. If the patient's feet hit the floor, we talk about their shoes. So we don't let patients walk around in slipper socks. They need to have shoes on. How many of you guys have ever been a patient at a hospital? They give you a gown and those little slipper socks, don't they? And you probably walked all over. You probably even walked to the bathroom in those slipper socks. And then you got back into bed with those slipper socks on. What got into bed with you? Oh, yeah, all those pathogens that were on the floor of the bathroom, and they cuddled right up next to you when you were sleeping. Are these Walmart germs? Nope. Should patients be walking around in slipper socks? Nope. We have to make sure they have shoes on. Slipper socks are not enough. Okay? Good? Make sense?
Is it different when a patient can't walk, like just if they're like in a wheelchair? Do they still have to wear shoes?
Still should have shoes on, because even in a wheelchair, injury is possible. You know, the toes can get smushed or separated. There's a lot of potential for injury. And especially with the feet, if your patient is older or has diabetes, they may not be aware of any injury that actually occurs. So we have to talk about their shoes. If they don't have shoes, we got to let the nurse know. Nurses can solve that problem. I've got social workers. I can call up a social worker and say, hey, I've got a homeless patient here who has no shoes. Get us some shoes. I can call the facility. Hey, Henry is here. Send his shoes over. I can call the family. Hey, Martha needs some shoes. I don't want her walking on this germ-filled floor with her socks. Bring me some shoes. I've got resources. But what I need to know is that she doesn't have any. That's where you come in. All right, so all of that just to know how to do foot care and what we're looking for here. So this is pretty easy. We're going to soak the foot. We're going to take it out, put it on a towel, and wash it. Putting soap on the washcloth, not in the basin. We're going to put the foot back in the basin to rinse and take it out and put it on that towel to dry it. We'll dry all areas. We'll blot between the toes because we don't want moisture there. We're going to apply lotion everywhere but between the toes, and then we'll put the sock and the shoe back on. The whole purpose here is to look at the foot. So during the test, you have to say something like, I'm looking at the foot. Or, I don't see any abnormalities. I'm not seeing any wounds. Skin looks good. You got to say something so that the evaluator knows that you know why you're there. Then when you put the sock on, make sure you minimize wrinkles and secure the shoe however it needs to be secured. I will tell you for the test, they're pretty good about looking for somebody that has slip-on shoes. Like you would be a great candidate for foot care because you don't tie your shoe, they just slip in. So when you get checked in for the test, those evaluators are looking at things that you don't even know they're looking at, like your shoes. Isn't that funny? All right. So let me look at the care plan one final time before I show you the skill. It says provide foot care to 1 foot using soap and water. The resident is sitting in a chair and their sock and shoe should be replaced at the end of the skill. All right, so go ahead, Jake, and show this video, if you would.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
Wonderful. I need to do foot care. Is that okay?
Yes.
Let me go close your curtain, wash my hands, and then I'll gather your supplies.
Okay.
Okay, I'm going to get a barrier, and we'll place this on the floor right in front of you, and you can place your foot on the barrier. I'm going to get a basin, soap, and lotion. We'll place that on the barrier. I'm going to get 2 washcloths and a towel and a set of gloves. I'm going to get some water for washing. Okay, Mr. Jones, would you like to check the water temperature and make sure it's okay?
Yes.
Is it
Great.
good?
Yes, great.
Very good. I'm going to set this here. And I'm going to kneel on the barrier and apply my gloves. I'm going to roll up your pants leg and lift your foot so I can remove your sock. We'll place your foot in the basin to soak. I'll take the first washcloth and wring it out, making sure that your foot is wet. I'm going to place your foot over here on the towel and apply soap to the washcloth. I'm going to wash all surfaces of the foot. I'm going to lift your foot up so I can wash the bottom, and I'll observe for any red areas, wounds, sores, or any other abnormalities. We'll put your foot back in the basin to rinse. Okay, I'm going to place your foot on the towel to dry. And I'll ensure all surfaces have been dried thoroughly. I'll take one of the narrow edges and go between your toes to blot. And I'll dry the bottom of your foot. Now I'm going to apply some lotion. We'll warm the lotion in our hands. And apply lotion to all surfaces except between the toes. So I'm going to lift your foot, and we'll apply lotion to the bottom as well as the top. And now I'm going to wipe off the excess lotion so that you don't slip. Okay, go ahead and place your foot back on the barrier. And now I can reapply your sock. There you go. And we'll put your shoe back on. Can you slide your foot in there for me, please? Okay, Mr. Jones, I need to put all of my supplies away now. I'm going to gather my dirty linen and place it in the dirty linen hamper. I'm going to take the basin to the sink and clean according to the basin cleaning procedure. On the way back, I'll collect the soap and the lotion and put the basin back in the drawer. Now I'll collect the barrier and throw it away. Now I can remove my gloves. Okay, Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is here. If you should need anything at all, please let me know. Can I get you a magazine while you're waiting?
No, thank you.
I'm going to open my curtain and wash my hands. After washing my hands, I'll review the steps in my skill, make any corrections, and tell the evaluator my skill is done. All right, go ahead and take your break, and we will resume in 15 minutes. Hold on. 62. we're back. Okay, any questions before we go on? This next skill is one I really don't have to teach you much for. It's mouth care. Everybody knows how to brush teeth. Not much here to learn. You know all of the principles involved. We're going to follow the care plan. We'll do our opening. We're going to wear gloves because there's body fluids involved. We need a barrier to put all of our supplies on. Linen rules are going to apply because we need a towel. You don't want to hold it up against your uniform. Anything extra you take gets discarded. We're going to clean the basin the same way we clean all basins, and we're going to do our closing. Nothing here to learn. The only problem here is that our patient is laying in bed. So that unfortunately leads to a few complications that we have to talk about. So at the top of page 93, you see the care plan for this skill. It says a resident with natural teeth is lying in bed and needs mouth care. The resident is not able to provide their own mouth care. This is a live patient skill. So one of you may be getting your teeth brushed during the test. It's not a hard skill. We're just brushing teeth. But since they are laying in bed, we need to get them sitting up. Now, step-by-step instructions are here, and I want to bring your attention to step 7. Step 7 is going to tell you to use a barrier to put the head of the bed up, between your finger and the bed controls after you've done your opening. And the reason for that is going to be a little bit different than what you're going to follow this. Always follow this. So remember when we learned the opening, our cardinal rule was we can't touch the resident until our hands are clean. Well, that bed control is not clean. So putting the head of the bed up before you wash your hands, perfectly okay. That's fine. You can do that. The problem is that when you put the head of the bed up, that pillow that's behind her head looks very comfortable when she's laying down. But when you get a patient sitting all the way up, that pillow behind their head forces their head forward. This is not a safe position for mouth care. So we need to get that pillow out from behind their head, or better yet, have them sit forward and place the pillow behind their upper back. So this gets them sitting upright for mouth care. We can't touch that pillow before we wash our hands. You can put the head of the bed up, but you can't adjust the pillow until your hands are clean. But the way to get around this, and there's a couple of different ways to do it. Just remember, you can't touch the patient until your hands are clean. However you decide to do this, as long as you remember that, don't touch the patient or the pillow until your hands are clean. As long as you remember that, you're okay. There's a couple different ways you can do this. The best way, I think, is to do your opening, wash your hands, and then use a paper towel between your hand and the bed controls to put the head of the bed up. And that's what this is going to show you. And then you can adjust the pillow because your hands are clean. Any questions on that? That's probably the hardest part of this skill. Now, some of you are going to ask, wait, what about dentures? Are we going to learn about dentures? Yes, we are. On Monday, we're going to learn how to do this skill with dentures. But for this skill, your patient has their own teeth. So we'll go through the skill-specific steps one by one here, but again, there's not a whole lot to learn. Your patient has to be sitting fully upright. You cannot brush teeth with a patient laying in bed. So we got to get them sitting up. That's a checkpoint. If you don't raise the head of the bed, the patient may aspirate. Now, that's a medical term you need to know. Aspirate means breathing fluid or food into the lungs. We don't want to do that. That can lead to pneumonia and other issues. So we need to get them sitting up. We can use a paper towel to keep our hands clean while we do that. Once we get the patient sitting up, we're going to put a towel over their chest, and this is going to help protect their clothing. Now, nobody's going to die if you don't put a towel over their chest. You know, their clothes are probably going to get all toothpasted up, but nobody's going to die. So that step is not going to count as much as putting the head of the bed up. Every step is going to be weighted differently depending on how important that step is to the patient. Good? Okay. When we're going to put toothpaste on the toothbrush, when you're doing this at home on yourself, it's a little bit different because if you need more water, the sink is right there. It's probably even running and you can get more water on your toothbrush to get everything to, spread around evenly. When you're standing at the sink, brushing teeth is a little bit different than when you're trying to do it over here. Over here, you got to make sure everything is ready before you get started. So we really want to make sure that our toothbrush is wet before we put toothpaste on it. That allows the toothpaste to spread across the surface of the teeth very well. If you put toothpaste on a dry toothbrush, that paste gets all tangled up in those bristles and it's not going to spread across the surface of the teeth very well. You're going to end up with big globs. Now, if you're standing over a sink and you got big globs, you'll just spit them out. But this patient is going to have trouble doing that because they're in bed. Good? So one of our rules here is that we want to wet the toothbrush before we put toothpaste on it. We're going to brush whatever they got. Top, bottom, front, back, tongue, brush. Nobody cares how long it takes. They're not timing you. You don't have to brush for 2 whole minutes. There's nothing like that. It's not timed. Just brush. Brush whatever they got. Once you're done brushing top, bottom, front, back, and tongue, then we're going to let them rinse. You got to let them rinse as often as they need to, as much as they need to. But here's a hint. If you use a lot of toothpaste, this patient is going to be rinsing forever. So for the test, you really don't need more than a pea-sized amount of toothpaste. That gets the job done. But we usually use like this great big long stripe or something. Just a pea-sized amount is all you need. And it makes rinsing a little bit easier, especially when your patient is in bed, because all of that extra toothpaste that's in their mouth that's bunching up because there's too much there increases the risk of aspiration. Pea-size amount is all we're looking for here. After they rinse, use that towel to dry off their face. Don't leave them a wet, drippy mess. Nobody wants to be a wet, drippy mess. So that's it. Those are all the steps. That's it. That's all you need to know to do mouth care. This is, I think, the easiest skill because it's one that you do every single day. There's nothing to learn here other than put the head of the bed up. You also need to wear gloves for this one because of body fluids. Don't take your gloves off until you're absolutely done cleaning your environment. The basin is clean, put back in the drawer. The patient is cleaned up. Wait to take your gloves off until everything is done. All right, good. I'm going to show you the skill for this one, or the video for this one too, because it's got good close-ups. And I can never get a volunteer for mouth care. So let me show you a video for this one.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to do mouth care. Is that okay?
Yes.
Okay, I'm going to put the head of your bed up. And then I'll close the curtain, wash my hands, and gather my supplies.
Okay.
We'll get you to a full upright sitting position for safety. And if I can get you to lean forward, please. There you go. Is that more comfortable?
Yes, much.
Okay, I'm going to close your curtain and wash my hands now. I'll gather my supplies. I'm going to start with a barrier, and we'll place that on your overbed table. I'm going to get a towel, a set of gloves, a basin, toothbrush and toothpaste, and a cup of water. We'll prepare the toothbrush first. Going to put the head of the bed up after, sorry.
I got it.
Okay, we're going to put the head of the bed after we wash our hands. These videos are a little bit older. I'm getting ready to do the newest one this weekend for this skill. Remember that follow what I say, not what the video shows for that. So wash your hands and then put the head of the bed up. We'll get it wet, place a little bit of toothpaste on it, and set it in the basin. Mr. Jones, can I place this towel over your chest?
Yes, please.
Okay. And now I'll apply my gloves. Okay, Mr. Jones, can you open wide for me? I'm going to brush the back on the bottom. The back on the top. And can you bring your teeth together? And stick your tongue out for me. Thank you. Set that aside. Go ahead and take a sip. Rinse your mouth. Let me wipe that off for you. Another sip.
No, thank you.
Okay. Now I'm going to dispose of my cup, wrapper, and toothbrush. I'll be right back. I'm going to remove the towel and place it into dirty linen. Going to go clean the basin, and I'll be right back. I'll place the toothpaste in the basin, use the paper towel to open the drawer, and place the basin and toothpaste in the drawer. I'll clean up my work environment and go throw these items away. Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No,
A
thank you.
magazine?
No, thank you.
Okay, your call light is right here. If you should have any needs, let me know. Can I adjust the head of the bed for you?
No, this is great.
Okay, I'm going to open the curtain and go wash my hands. After washing my hands, I'll think about my skill, make any corrections I need to make, and then tell the evaluator my skill is done. All right. Okay, any questions on mouth care? It really is one of the easiest skills you guys have to do because you're familiar with it. It's also one of the ickiest because nobody likes to brush somebody else's teeth. I get that. Remember that your patients aren't going to want you to brush their teeth either if they can do it. So we're only doing this on patients that cannot do it on their own. Ashley has a question. She asks, if a patient requests a shave while we're setting up for mouth care, can we assist? So let's stop there for 1 second. Let's answer that one first. Can we assist somebody with any skill? How do we know what skills to do on patients? The care plan. So the answer to this question is it in the care plan? Now, if you remember class 1, I gave you a very important statement on your scope of practice. CNAs perform routine tasks on stable patients that they have been trained to do according to the care plan. You guys remember that statement? So let's look at this question in relationship to that statement. So CNAs do routine tasks. Is shaving a routine task? Is shaving something that people do every day? It can be, right? So it can be a routine task. Is our patient stable? Well, this one seems to be pretty stable. Now, the third part to that is that we have been trained to do. Okay. Remember, we have to be trained to do a task in order to do it. So shaving is not a tested skill. So we're not going to go over that in class here, but it is in your yellow book. Your yellow book this weekend is going to tell you how to shave patients. Now, most cases, the majority of cases with shaving, the majority of cases with shaving are going to be done with an electric razor because there's less risk of injury. So the majority of shaving that CNAs do are with an electric razor. You can shave with a razor and shaving cream, perfectly okay. Hartman will tell you how, but electric razors are better. However, if the patient is on oxygen, we can't use an electric razor because of the risk of sparks. Because facial hair can be really coarse, and the friction of going over coarse skin with electric shavers can cause a spark. So how would we know which method is required for this patient? Care plan. So if the care plan is telling us to shave the patient with an electric razor, the patient is stable, and we feel comfortable with doing it because we've been trained, then it's perfectly okay. If you are deciding that the patient needs to be shaved, is that okay? If you are uncomfortable shaving somebody because you've never really done it before by yourself, is it okay? No. You would just have to let the nurse know, hey, I'm not real comfortable with that. I haven't actually done it yet. And they go, oh, cool. Come with me. I'll show you how. Now you've been trained. Make sense? So any questions that you have like that? I love that question. It's such a good question. Any questions, always go back to that statement we learned on day 1. Routine task, stable patient that we've been trained to do according to the care plan. If those 4 things don't exist, it's not your task. Good? Because there's going to be a lot of things out there, a lot of tasks that you're going to have questions on. So always go back to those 4 things. Is it routine? Is it a stable patient? Have I been trained? Am I comfortable? And is it on the care plan? If the answer is no, the answer is no.
Let's just say if the nurse wants you to do something and she trains you to do it. Are you allowed to do
Absolutely.
what she trains you and she puts in the care plan, like, hey, I want you to do this.
Absolutely. And care plans can even be verbal. So as a nurse, I can tell you to do something. It doesn't have to be written. It can be verbal because I am ultimately taking all the responsibility for everything you do. So if I ask you to do something, I'm taking responsibility for it. So if you aren't comfortable, it's not in my best interest to have you do it because ultimately I'm liable. Right? So asking you to do something that you're not trained to do or you're not comfortable doing is going to come back on me if something goes wrong. Make sense? Remember, it should never be you versus the nurse. It should be you and the nurse versus whatever's trying to kill the patient. Make sure you're on the right team. Otherwise, the patient suffers. So common question, do I have to brush everybody's teeth? And the answer is no. If somebody can brush their own teeth, they're going to. They do not want you in their mouth. They do not want you in their mouth if they can do it themselves. But you may have to set up, right? You may have to bring the stuff for them to do it. But if they can brush their own teeth, they probably will. We're going to go by the care plan.
So if we're talking about mouths right now, how about if someone needs help eating? And if it's in the care plan, do you help that patient eat?
Absolutely. We're going to learn how to feed a patient next week. Yep, we're going to learn all about feeding next week. I've actually got a lot. That's a simple skill too, but I've got a lot to tell you about it because we have to talk about intake and output, documentation, and conversion from ounces to cc's.
How about anything like they can't eat and just say, like an example, they're on a feeding tube. That's not a CNA's job.
That's not a routine task. Eating, something you do for yourself every day. That's a routine task. Feeding tubes, not routine. Not routine. And in fact, as a nurse, if I want you to do a task, I have to look at 3 things before I can delegate a task. Number 1 is it allowed by the state? Okay, because there's roles that are defined. Florida's pretty wide open. Number 2, is it allowed by the facility? Now, for that, I have to look at the policies and procedures. And number 3, is this something that even I can do? Like, I can't delegate doing a tracheotomy on somebody because that's not even something I can do. So I have to look at those things before. There's a couple more rules that we're not going to get into, but those are the 3 main ones that concern CNAs. So in order for me to delegate, I have to know the laws. I have to know the facility's rules, and I have to know the task itself so that I can either provide training or evaluate your performance. Okay, good. Makes sense? But yeah, you can be trained to do all kinds of things beyond what you're learning in this classroom. Tons of things. It depends on the setting that you're working in as to what you're going to learn. So for instance, if you decide to go to work in dialysis, and all of you guys can work in dialysis, they train. Remember, routine task, stable patient, trained, right? So they train. So dialysis is routine. It's something that they do 3 days, 3 times a week. Pretty routine. Patients are stable. If they're not stable, then the nurse has to be the one to do the dialysis, not you. But you can certainly be trained to do those things. Now, that's a very technical situation, very technical skill. You've got to be able to access the shunt or the graft using a very special needle. You have to know how to set up the machine. You have to be able to access the blood and run it through the analyzer to make sure that the machine is set up properly. So very technical steps involved there. So you would have to go through training to do all that. You wouldn't be able to do that tomorrow. You might get hired tomorrow, but they've got to put you through training to master all of those steps. Good? Does that make sense? Now, if you go to work at a mother-baby unit, you're going to learn to swaddle. Very important with newborns. Very important. But you're not swaddling adults. So if you go to work in a dementia unit, you're not swaddling anybody. So it depends on the setting that you're in as to what new skills you're going to have to learn. Okay? I wanted to point this out. On every page in the book and every skill, there's a knowledge section, some questions related to that skill. If you can answer these questions, then you know what you need to know for that skill. All right, so this is our last skill for today. And this is measure and record respirations. This is a super easy skill. It takes no time at all. It is the most assigned skill on the state exam. This shows up on more care plans than any other skill. It's the most assigned skill. So you have a pretty high chance of getting this skill on the state exam. It's a super easy skill, not much to learn. And then after we learn this skill, I'm going to pass out, or Jake's going to pass out the test registration packets, and we're going to go through test registration. Okay, so that's what's left for today. So okay, let's start down here. I'm going to move her in a minute. Let's start down here. So somebody, this testing information, somebody with your level of experience should be able to do this skill in 5 minutes or less. We're going to read the care plan in a minute, and you're going to see why that's way more time than you actually need. This is going to be done on a live testing student. So somebody live will be laying in bed for this skill. It's a documentation skill. Anytime we count something, we have to document it. Normal is between 12 and 20, and you can be off by 2 breaths in either direction. So if normal is 12 to 20, right? Normal breathing. You breathe 12 to 20 times a minute, normally. If you can be off by 2 breaths in either direction, let me show you how big of a margin that is. So let's say the evaluator gets 14. So remember, the evaluator is going to count when you do. So the evaluator says this guy breathed 14 times this minute. If you got 12, 13, 14, 15, or 16, you're still accurate. That's half of the range, guys. So this skill isn't about accuracy. It's not about how accurate you are. It's about, did you follow the care plan? That's what they're grading you on this skill. It's that simple. Did you follow the care plan? Nothing new to learn here. We know all of these principles, all of them. Nothing new to learn. So let's talk about skill-specific steps. The care plan at the top of this page, sorry, let me get past you. Care plan at the top of this page tells us the patient will be lying in bed for skill. Count the patient's respirations for 1 full minute and record your reading. So how long are we counting for? 1 full minute. If you do not count for 1 full minute, you will fail. It's that simple. If you do not count for 1 full minute, you will fail. Come on, Sally Mae. Okay. Very few supplies needed for this one. We need a clock, which will be right above the bed in the clinical setting, just like we have here. There's a clock right above the bed. We're going to have a live person in the bed for the test. But when we are doing this, we do not want to tell the patient that we're counting their respirations, because if we do, it alters their breathing pattern. So I need a volunteer. Somebody come lay down in bed for me. We always have a designated patient. I don't know why. Go ahead and lay down. It is. All right, so if I come up to her and I say, okay, I'm going to count your breathing. Ready, set, go. Right? She'll either hold her breath or she's going to breathe a whole lot faster because she's now aware of her breathing. And that's why we don't really want to say out loud, I'm going to count your breathing. What I'm going to do instead is tell her I'm counting your vital signs. Respirations is a vital sign. So we're not lying to the patient, but we aren't making them hyper aware of their breathing either. But there's another problem with this. If you just stand over a patient, I'm going to try to turn this, there we go. If you just stand over a patient, how comfortable are you right now? Pretty uncomfortable, aren't you? Yeah, you can't just stand over somebody and not touch them and stare at them. It's creepy, especially for 1 full minute. Do you guys remember how long a minute was with pulse? That's a long time to be standing here. Weird, right? Weird. You can't do that. That's going to make your patients anxious. Anxiety elevates the heart rate, but it also elevates breathing. So if you're making your patient anxious, they'll start breathing faster because they're anxious. In and out is counted as 1. So that's 1. It doesn't matter whether you count on the inhale or the exhale. The whole thing is 1. So in and out counts as 1. Remember, normal is between 12 and 20. In and out counts as 1. How long do you count for? Well, as long as the care plan tells you to. And this care plan says 1 full minute. If our care plan does not specify, we're going to use the same thing as we did with pulse. 15 seconds, multiply that by 4 to get our full minute reading. But this care plan does say 1 full minute. So how long do we have to count for? 1 full minute. All right. So 15 seconds multiplied by 4. Normal is between 12 and 20. This is the documentation form that you will be using for the state exam. You can see it in the middle of the page there. You also have a full-size version of this on page 168 in your skills book. You've got a full-size version of this. And you're just going to write on that line how many breaths the patient took. Now, a question I get asked a lot is, well, how do you count the breathing and look at the clock at the same time? Do you guys remember how long a minute was? It's like a long time, right? So I'm going to look at the clock. I'm going to pick a starting point. I'm going to say start, and then I'm going to focus here. Because if I focus here, I know normal is between 12 and 20. I don't even need to look at that clock until I get to 10 and see where I'm at. And then I'm going to glance at the clock a little bit more frequently as we get closer to that minute reading. Good. Now, there is a way to make this easier to see. And you really should use this on the state exam. It's perfectly okay. It's a cheat, but it's okay. And if you look at her tummy, you can kind of see it going up and down, but it may be kind of hard to see, especially because she's got a dark shirt on. But take a look at her tummy. I know everybody's going to look at you in a minute. Take a look at her tummy and see if you can see it going up and down. You guys see it? Okay. Now for the test, you probably don't want that evaluator like right there. You want that evaluator as far away from you as you can get them, because otherwise you're going to be nervous if they're standing over you. So you can do this. Just breathe. Do you see how that makes the respirations more visible? It's easier to see. This is psychology. I did not alter her breathing. What I altered was your ability to see it. Psychology. I messed with your mind. And that's because your vision is always directed to movement when it's a contrasting color. This is what kept us safe in the caveman days. We're drawn to movement when it's a contrasting color. So by putting an alcohol pad on her tummy, it contrasts with the color of the clothing, and it will draw your attention as it moves up and down. You can use this for the state exam. Perfectly okay. But I'm not going to stand over here and just stare at her tummy counting. I want her to think I'm taking her pulse. If she thinks that I'm taking her pulse, she won't focus here. So when I do this skill, I'm just going to hold her wrist, keeping her elbow on the bed. I'm not finding her pulse. I'm just holding her hand, really. And that allows me to look here, but she's focusing here. Good? Questions? These are in the drawer or on top of the 3-door unit. They're always available. Okay, so I'm going to do this whole skill from beginning to end. I'm going to simulate hand washing because it's not my first skill of the day. I'm going to simulate hand washing. When I put the alcohol pad on her tummy and say start, I want you guys to count her respirations while I do. Quietly to yourself, count the respirations. At the end of this, I'll tell you what I got and we'll see how close you were. Okay? Can I have the clipboard? Thank you. All right, here we go. Good morning, Miss Jones. My name is Patty. I'm your CNA today. How are you? Good. I need to get your vital signs. Is that okay? I'm going to close your curtain, wash my hands, and I'll be right back. I've just washed my hands. All right, Miss Jones, I'm going to do all the work here. I just need you to remain quiet. This will take me a full minute, though, okay? Just need to lay this here for a minute. I'm going to hold your arm. Everybody ready? Can you see? Ready, set, start. Stop. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Your environment is clean. The bed is in the low position. Here's your call light. If you need anything at all, just press that red button and we'll be happy to come help you. I'm going to open the curtain and go wash my hands. Now that I have clean hands, I'll document my reading. Wash my hands again. After washing my hands, I'll think about my steps, make any corrections, and tell the evaluator my skill is done. Thank you. Did you notice that her breathing slowed down the longer we did this? When we first started counting, she knew she was being watched. Her anxiety went up and she was breathing faster. As she laid there for a few minutes and kind of settled into it, her breathing started to slow down a little. So we actually got to see that happen in real time. What did you guys get? Okay. 21? Oh, okay. So 20, I got 21. So 21, 22, 23, 20, 24. Any of those will work. Any of those will work. Good. The reason that we got a little above normal is because she was nervous. She was anxious. But because we did get over 20, who would need to know? The nurse. That's right. All right. Any questions? Remember, this is the most assigned skill. Respiration shows up on, I think it's 5 testing care plan sets. So you're pretty likely to get this particular skill. Okay. Questions? All right, so let's talk a little bit about documentation. This was the documentation form that I documented on. And remember, you've got copies of this in your book on page 168 and 169. But when it comes to documentation, there's a couple principles you need to be aware of. Now, most settings don't allow CNAs to document in words. Medical records are legal forms that can be called into a courtroom. So everything written on a medical record can be subpoenaed. Because of that, we don't usually let CNAs write words because they can be called into court. most of the time, CNAs are only going to document in numbers like pulse, respirations, blood pressure, the amount of urine in a bag, the amount of food that was eaten based on percentage. So most of the time, CNAs document numbers, hard and fast. Words are usually used by nurses, but there are some settings that will require CNAs to document in words. And if you do, there's a couple principles that you need to be aware of. First of all, documentation must be done in ink. And most places require black ink. It's actually a Medicare requirement, black ink. If you're going to document in words, you need to be accurate, brief, but complete. You don't want to ramble on and tell this long, drawn-out story. You want to just give the facts, just the facts. And when you're documenting, you want to avoid the use of I statements. I went into the room and I saw the patient was laying on the floor, so I went and got a nurse and I helped the patient up and into a wheelchair. Now the focus is on you. Who should the focus be on? The patient. So that would actually be better documented. Upon entering the room, the patient was found to be on the floor. So that puts the focus on the patient, not on you. So we try to limit the use of I statements. We want to be brief. You don't want a 2-page story. You just want to tell the facts. So be brief, but give the whole story. Good? If you make a mistake, we put one line through the mistake, write error above it in our initials. You never destroy a legal form. Not our job. You can't bundle it up and throw it away. Medical documentation never gets destroyed. One line, error, and your initials. Don't use whiteout. We don't conceal anything. Remember, this is a legal record. We are not allowed to conceal anything on a legal record. So this is, because of all these rules, this is usually why CNAs are only allowed to document in numbers, not words. But this gives you a good overview of documentation principles if they're needed. Now the next page, page 49, talks about military time. If you're not familiar with military time, I would do this activity because healthcare uses military time. And to me, it just makes way more sense. Military time just makes way more sense. I want to know who the bozo was that said, hey, there's 24 hours in a day. Let's just use 12 of them. And then let's do that again. That makes no sense. If there's 24 hours a day, let's use 24 hours on the clock. And when you think like that, military time makes a whole lot more sense. It's just using all 24 hours instead of getting to 12 and starting over again. Okay. So I've got an activity there for you to be able to learn military time. Okay. So Jake, can you, nope, because I just demonstrated it live. Can you pass out the test registration packets? All right, I've got instructions for you on my website. So Jake's going to pass out the actual registration forms. We're going to go over them together in class. But if for some reason when you get home, you've got questions about this process, if you go to 4YourCNA.com, under testing, you'll see test registration instructions. And on this page, I have two things. I have a video where I actually do a registration on the screen in front of you, so you know what to put where. And then I have step-by-step slides that show you every single step. So instead of having to start and stop the video to get the steps, just go down a little bit more and the slide-based presentation will let you follow along at your pace. So watch the video for an overview and then the slide-based follow along. Okay? All right. So this packet that you have in front of you, This page in the front is what I want to talk to you about first. This is your roadmap, your blueprint. This tells you what we're going to do and when we're going to do it. There's 4 steps to the registration process. The first step is to make sure that you have a level 2 photo-enabled background check on file. Some of you already do. If you're working in healthcare and you had a level 2 background check done with a photo in the last 5 years for healthcare, you might already have this. There's no way to check. There's no way to check. So if you're unsure, then you need to just go get your level 2 background check. Okay, so if you're on the fence, not sure, just go get one. But if you are currently working in healthcare and you know that you have a level 2 with a photo for medical, they can find it. All right, so the first step there is to get the background check. After we get the background check, then we're going to submit our application. We're going to go through that step by step in a minute. Once we submit that application, in about 3 to 5 days, we're running a little bit behind right now, and I'll explain why in a minute. But about 3 to 5 days, you're going to get an email back from Prometric. You're going to open the attachment of the email. And when you open the attachment, you're going to see something that looks like this. This is what the attachment is going to look like when you open it. That's what it looks like. Now, this is your specific information. And there's a couple things you need to look at on this paper. The first is right here. It says application status. If that says complete, it's good. You got everything in. They got your money, they got your registration packet, and they got the background check. You're good to go. If it says incomplete, you're going to have to find out what they're missing. And that usually requires a call to Prometric. And then you're going to go down here where it says FBI background status, and you want to make sure that that says record found. So if this is incomplete, but down here it says record found, that means that your application is incomplete, but they found your background check. So that's not it. So it's either payment or something was wrong with your registration. Good? So you want to pay attention to those 2 boxes. Now at the bottom, it's always going to say pending approval. It will always say that, pending approval. So let me explain to you what's happening here, what the process is. So when you register for the state exam, you are registering with Prometric. When you get your background check done, that goes to something called the clearinghouse. The clearinghouse is a Florida Division of Medical Quality Assurance entity. So the background check is not Prometric. 2 totally separate things. So your background check, your registration are in 2 different places. When you register with Prometric, Prometric goes and gets your background check and puts it with your registration packet. Prometric cannot approve you for testing, not their job. All they do is gather that information and they send it to the Board of Nursing. This is an eyes-on event. A human has to look at your registration packet and your background check and say, yes, this person can test. A human. It's not automated. So this process takes a couple of days. So you register for the test. Prometric gets your background check from the clearinghouse, bundles it up, sends it to the Board of Nursing. A human has to look at that and say, yes, this person is okay. And then they send that approval back to Prometric. When Prometric gets that approval, you're going to get another one of these. And down here, it's going to say approved. That means that everything went to the Board of Nursing. Board of Nursing said yes. and sent it back to Prometric. You don't have a test date yet. It just says you're approved for testing. 1 to 3 days later, you're going to get another email from Prometric that's going to look like this. Sorry. This. And this is your authorization to test, or ATT. This is going to say, hey, not only are you approved, here's your test date. And at the top, it's going to tell you where you're going to be testing and what test you're going to be taking. Now, for you guys, your first-time testers, you're taking both the written and the skills on the same day. But if for some reason you fail one section and you have to retest, it's only going to list the part that you're retesting. Good? So you guys understand the process? You get your background check done. It's got to be in the clearinghouse. You register. Prometric goes to the clearinghouse, pulls background check, bundles it up, sends it to the Board of Nursing. The Board of Nursing approves you, sends it back to Prometric. You get an email saying approved. You're going to wait, bless you, a day or two, maybe 3. You're going to get another email that gives you your test date and location. That's the process. Now we're going to go through the specifics. Everybody go with the overview, though? That's what this is telling you, expected times for all of this. But right now, we're going into busy season for testing. In the spring, every high school that has a CNA program is testing before graduation. There's a lot of them. Every community college is testing. There's a lot of them. Every trade school that graduates in the spring is testing. There's a lot of them. So right now, there is a bit, you guys are like right on the very beginning of what we call busy season. So you may not have a long delay, but those in April and May, this process can take like 6 weeks just because of the sheer volume. They only have so many evaluators. And if all the evaluators are busy at the high schools, there's nobody to test you. Does that make sense? So keep in mind that this process usually takes about 3 weeks from background check to testing date. Usually takes about 2 to 3 weeks before you get your testing date. For you guys, it might be just maybe a week longer. Those in April and May, it could be 3 or 4 weeks longer just because of volume. Good? Good. Okay. So, this is Prometric's website. If you go to prometric.com/nurseaid/FL, they've actually changed their website, but this will still redirect you to their new URL. But if you go to this website, this is what it's going to look like. And on this site, you're going to have contact information for Prometric on the side. You're going to have application process, candidate resources, training program, registry, and important changes. If you click on this, it opens up. Those are called accordions. That section will open up. And when it opens up, it gives you a whole lot of stuff there. And this is why we have to go through this in class, because if you look at this, you're just not real sure what to click on. There's a lot there. So we're going to start with the background check. Now, on this paper, I gave you Deontis, which is who I recommend for a background check. We're going to go through how to do that in just a minute, step by step. I recommend Deontis. Now, you can go to a million different places. If you go to candidate resources, down toward the bottom, it gives you a fingerprint vendor list. If you click on that, it'll show you all of the places that are approved for CNA or medical background check collection. The sheriff's office does do them now, and they're a whole lot cheaper to do through the sheriff's office. But the people that went in December through the sheriff's office had a whole lot of trouble getting a test date. The people that went through this company got their test dates like this. So there's, even though you can do it at the sheriff's office and it is a lot cheaper, there seems to be a disconnect there somewhere. I don't know where. It's not my level of expertise. That's why I kind of tell you this is probably a better option for you. But if you go to Deontis.com, you're going to create an account. You got to do a super secret password with letters and numbers and symbols, you know, all that kind of stuff. Once you create your password and you log back in, you're going to have to verify your email and log back in. You're going to get this page. And this is where students start to freak out. Wait, which one do I choose here? Because it doesn't just say CNA testing. You want to choose Florida Services. When you choose Florida Services, and we're going to register for a background check, you need an ORI number to complete this process. The ORI number is this right here, EDOH 0380Z, and I've got it in that first column in the gray box. It's there for you. You have to have that. What that number is it's a routing number. It says, okay, this person is getting a background check for CNA testing. This background check needs to go into that filing cabinet over there so Prometric can find it. So you need that number. And that's going to be put in the ORI number field. When you put the ORI number in there, EDOH 0380Z, when you put that in there, it's going to bring up CNA by exam. Yay, we got the right one. That just verifies. We're going to hit next, and then it's going to ask us for something else. It's going to ask reason for request. We want other employment and licensing because we're going for a CNA license. So this up here, they do background checks for firearms, for volunteers in healthcare, for criminal justice, for childcare. They do all kinds of different. It's asking, what do you want yours for? Ours is for licensing. And then once you click that, it's going to ask you for an OCA. We don't need that. That doesn't apply to us. That's for employers. We need it for licensing. So skip the OCA. You don't need that. And then it's just going to ask you for your personal information. Put your name, your address, your social security number, all of that kind of stuff in there. And when you get all done with that, it's going to ask you, okay, cool, we'll do your background check for you, but where do you want it done? So if you put your zip code in there, it's going to bring up the closest one to you. For us, it's the UPS store on Barclay. Now, you can just walk in and do this. You don't have to register online. You can walk in and do this, but they're going to charge you $20 more because they have to put all this in the computer. And if they have to put it in the computer, they're going to charge you for it. If you register online, you save $20. So for me, I'll save the $20. So you put your zip code in there, you select the UPS store that you want to get your background check done. It's going to bring up a calendar. You can usually do same day appointments. So click on the date you want, click on the time you want, make your appointment, and then it's going to take you to the payment page. Right now it's as of the time that I did this, which was last fall, $76.68. Now, bear in mind, this may change a little bit because everything is going up. I don't know what they're going to charge you, but that's what it was. Put your credit card information, and then you'll get an email with a confirmation of your background check date. And then go get your background check done. When you go, they're going to take fingerprints, a picture, and a signature. They're not going to give you anything. You don't send anything anywhere. You just go. Go to the appointment. That's it. That's all you have to do. Go. They're not going to give you something to send to Prometric. It doesn't work like that. Remember that this has to go into a filing cabinet that Prometric goes to. If you are involved, if they give it to you and you send it to Prometric, yeah, we don't know how many of you guys know how to use Photoshop. that breaks the chain of custody. And guys, I'm really good at Photoshop. I can take your criminal history and make it disappear really quickly. That's why they can't have any person involvement. So they don't give you anything. You just go to the appointment and then they send that where you told them to send it using that ORI number. And once you get your background check done, wait about 24 hours. It'll be in the clearinghouse. It's pretty quick. It actually goes that day, but give it some time. About 24 hours later, you can now register for the test. Test registration is a little bit complex, and we're going to go through that now. So you can go to prometric.com/nurseaid/Florida and register online, which is what I recommend. The online registration is this packet that we're going to fill out together online. So what we're going to put in these spaces, you're going to use this as your template and put this information online. It speeds up processing. If you use this, that we're going to fill out, if you mail this in, it adds about a week or two of processing time because we've got to mail it to Maryland. Somebody's got to open it, type all of this information in, and then that starts the process. It takes a lot longer. So I suggest online registration for speed. But you can mail it in. If you're going to mail it in, the address is right here on this paper. The address is there for you to mail it in. But I prefer online. Now, at some point in this process, you may find that you need to contact Prometric for something. Either it says your application is incomplete or it's been taking forever and you haven't heard back. If you need to contact Prometric, this is where you find their contact information. There is an email, there's a phone number, of course, their address. They used to not publish this. This is relatively new. Prometric is not real good with customer service. They're not real good. If you have to contact Prometric about anything, understand that the person that's answering the phone does not know anything about your situation. Their job, they're minimum wage employees, and their entire job is to get you off the phone. Now, Prometric does testing for 1 million different services. Construction, IT, daycare. I mean, they do all kinds of testing, not just CNA. So when you call up, you're calling a number that the person answers doesn't know anything about any of these industries. So they're going to say, yeah, it can take up to 90 days to approve you for testing. Now I'm going to show you why that's not correct. Okay. I'm going to show you in just a few minutes why that's not correct. But when you call Prometric, that's what they're going to tell you. Your answer to that is not what the application says. I would like to speak to a supervisor. Do not listen to the person that answered the phone. You ask for a supervisor, and that supervisor can pull up your specific information. The person answering the phone can't. Does that make sense? They're not good with customer service. They're getting better. Don't yell at me. You're getting better. But it may take getting a supervisor to get an answer. All right, so when you're on Prometric's website, under application process, there's an online application form, which is exactly what you've got here, just online. So let's go through this step by step so you know what to put where and there's no delays in your processing. Paper application is what I printed out for you. This is what it looks like. So in your packet, this is the page we're on. Actually, let's go back a page. Hold on. Let's do this first. This first 2 pages on the inside, the first 2 pages, these are all the testing centers in Florida. I've divided them up by region for you. If you look down here, At the bottom of the first page and the top of the second page, you can see Central Florida. That's us. Our closest testing center here is the very last one on the first page, a Gillis, where it says CNA TAMAIR. That means it's by the Tampa airport. That's all that means. So a Gillis is our closest. There's another one in Tampa at the top of page 2, Veritas. And then there's one in Temple Terrace as well. If you're in Citrus County, there's a couple in Ocala, which you can actually see in toward the top of Central Florida. So you want to pick the testing center that's closest to you. So like I said, for us here, the last one on page 1 is what you're going to choose. All right, so now let's go to this page. The first thing that you're going to see is a stop sign. It says, hey, please make sure that the name you put on this application is really your name, and you have 2 forms of ID that prove it's you. One of those forms of ID has to be a non-expired government-issued photo ID, like a driver's license, passport, state ID. The second form of ID has to have a signature, so like a debit or credit card, your social security card, your passport, a library card, but the names on both have to match. So make sure that the name you put on your application, you have 2 forms of ID that match that to prove that you are you. The reason that they do this is down in South Florida, they had a woman who was taking CNA exams for other people. Yeah, she would charge you like $500, $700, something like that. She'd go take the test for you and she passed it. And you would get your CNA certification. They are serious about making sure that you are indeed you and you're not testing for somebody else. Okay. And I've had students that went to test and they did not have 2 forms of ID and they were told, I'm sorry, you cannot test today. And they are out $155. So please make sure that you have 2 forms of ID that match. Down below, it's going to ask you if you need ADA accommodations. This is the American Disability Act. So if you need a seeing eye dog or a sign language interpreter or I don't know, whatever physical accommodations you need for testing, you would check yes. There's a whole packet that you have to fill out on Prometric's website. You have to take it to your doctor and they have to fill out affidavits, and that's going to increase your test, the time to get to testing by about 3 to 4 weeks. I had somebody do this back in, I think it was September, and they were just approved for testing in January. So if you need ADA accommodations, please remember that it takes time for the testing center to be able to make those accommodations. So you're just going to check yes or no there. And then we get down to candidate information. Now you can do this part on your own. You can fill out your name and your address and all of that on your own. So let's go to the next page. Okay. So the top part of the next page is, again, your demographic information. You can fill that out on your own. And yes, you do have to indicate, I'm sorry, you do have to have a physical address. They will allow a P.O. box, but they will probably contact you for a physical address as well. So if you're using a P.O. box, please remember that they may need that physical address as well. The high school diploma thing, that's only, you have to answer that, but it only counts if you're under 18 years old. If you're 18 or older, they use it for data gathering, but they really don't care. So now let's go down to this part. This is the part that gets really confusing. So I need you to stay with me for a second. If you have a felony in your background, if you have a felony, I need you to see me after class. If you have no felonies in your background, for number 1, check no, and then skip A, B, C, and D. and E. So number 1, check no. Skip A, B, C, D, E. For number 2, check no. Go to the next page and skip A and B. Now let me explain to you what 3, 4, and 5 is about, because this is all legalese. There have been some doctors, and we have had some in our county, that were caught committing Medicaid and Medicare fraud. If you worked for those doctors and you were knowingly complicit in committing Medicare and Medicaid fraud, they would have taken you to court. They would have prosecuted you for that, and you would be on a list of people who cannot work in healthcare. If that scenario does not apply to you, if you have no idea what I'm talking about, you're going to check no for 3, 4, and 5 and leave all of the A's, B's, and C's blank. So if you have no felonies and you have not been committing Medicare or Medicaid fraud, 1, 2, 3, 4, and 5 should all be no. You should not have anything under the A's, B's, C's, D's, or E's. Good? I know, it's a little confusing. I know. All right, going down to the next section is disciplinary history. What they're looking for here is they want to make sure that you didn't knock around some old people in Florida or anywhere else, got your license taken away, and you want to try to do it here. So they're asking, have you ever had disciplinary action taken against a medical license anywhere? So if you've never been a medical professional, or if you've been a medical professional that has never had any sanctions against your license, your answer to all 4 of those is no. Do you see why we have to go through all of this in class? Because there's a lot to this registration packet. Then we get to the bottom and it's criminal history. You either have one or you don't. So there's only 2 choices here, yes or no. If you have a criminal history, put yes. If you don't, put no. If you're not sure, it's probably yes. Question below that is asking if you've ever had any records sealed. So you had a criminal history, but you paid a lawyer a couple $1,000s to make it all disappear. It didn't. We're going to find it. Declare it. The last question there is asking if you have a juvie record. We were all young and dumb, but not all of us got caught. Moving on to the next page, there's health history questions. I cannot help you with this section. I am not allowed to give you guidance. You read the questions and you answer them. Your social security number goes at the bottom of the page. We're going to skip that, and you can do that on your own. Now, we're going to get to the next page, which is labeled number 5. And I want to bring your attention back to the very first page that we talked about that gives you directions. Right here in bold, it says you must select E3 Challenger. You must select E3 Challenger. What must you select? E3 Challenger. I am so committed to this that I actually marked it off for you already. E3 Challenger. But when you go home and you put this information into the online registration, some of you guys get confused and you start checking other things. What do you need to check here? E3 Challenger. If you check anything else, you're not going to be allowed to test. I know we're sitting in a classroom. This is test preparation. It is not a state-approved program where we go in and do clinicals. You cannot check off E1 or E2. Now, if you've been a CNA since 2002 and you've lapsed, yeah, you can check off E5 if you want, but it really doesn't matter. E3, E4, E5, Doesn't matter. Everybody tests exactly the same. The only thing that matters here is if you check off E1 or E2 and you fail, it counts against the school. And they can lose their license to teach. That's what they're looking at here. 80%, 88% of all CNA exams are done to challengers. Very few people check E1 or E2. Okay. So what did you check? E3. And because we checked E3, this part doesn't apply to us because it says we only fill it out if we checked E1 or E2. We checked E3, so that doesn't apply to us. I've got a big X in there for you. And then coming down here, it asks, where are you wanting to test? Well, we're going to test at a regional test site. We've already looked at that, and we picked our test site just a few minutes ago. Remember the first 2 pages. So you're going to write the test site code right there. Now, if you're doing this online, there's a drop-down menu that lists all of the testing centers. So you'd want to know the name of the testing center that you're going to be testing at, and you're going to pick that in the drop-down menu. Good? All right. So we've checked off, or regional was already checked off for you. You're going to put the test site code in the box, and then we're going to get down to, we already picked ours. Then we're going to get down to the testing fees. For the majority of you, you will check the first box. The first box is your plain Jane test. It is clinical and skills, both in written or both in English. If you need the computer to read the test questions to you, if English is not your first language, if you have a learning deficiency or a reading disability, you can check the second option, and that has the computer read the questions and answer choices to you. Students tell me that reading the question, it actually can get very distracting and annoying because it's a computer voice and it's very flat because they can't give inflections. If they stress a word, then you know that that word's important. So it can get a little bit annoying to people that don't need it. So if you need it, check it. If you don't need it, check the first box. Anybody here more comfortable in Spanish than English? Okay, we can skip the rest of them then. So check the first box. If you need the computer to read the questions, check the second box. The testing fee is going to be $155. So we're going to write $155 in the total box next to the choice you made. Bring it down to the bottom, and $155 is what you're going to pay when you register. So if you're going to fill out this paper application and mail it in, there's a payment page we're going to get to in a minute. If you're doing it online, you're going to pay by credit or debit card on the online interface. Going to page 6 here at the top, you're going to fill out, it says yes or no. That is a box that indicates that you have received and read these last 2 pages in your packet. This is their privacy policy, how they're going to use your information to approve you for testing. I actually put it in the packet so that you can check that box that says that yes, you have received it. And then down below is an attestation. You can read that, or you need to read it before you sign and date it. That just says you agree to all of that stuff. Okay, once you've done that, at the very bottom of the page, this statement I want you to pay attention to. It says, if you do not receive your emailed ATT letter, you guys remember that authorization to test letter? Within how long? What does it say there? 10 to 14 business days. Remember I told you that when you call up, they're going to tell you 90 days. It can take 90 days to approve you. What does the application itself say? 10 to 14. Guys, this is their contract with you. This is what you say when you call up. The application says 10 to 14 days, or I'm supposed to contact you. It's been 14 days. I am contacting you. I want a supervisor. This is what gives you that ammunition. Good? Questions? Good. Okay. All right. So after you submit your registration, either online or by mail, you're going to get an email back from Prometric. Make sure it says application status complete. And under FBI, record found. As long as it says complete and record found, you just wait for your test date to come. If this comes directly from their website, if it has been more than 5 days since you submitted your registration and you didn't get that email back from Prometric that says application status complete, if you don't get anything back from Prometric within 5 days, it tells you to contact them. There have been situations where students have put their email address in and either forgot a letter or transposed something, and they're sending emails, but you're not getting them because the email address is wrong. You need to contact them if it's been more than 5 days because there may be an email address problem. Good. Make sure you open all attachments from Prometric because the attachments are what's going to give you your specific information. Open the attachments. I actually had a student about 2 years ago that she didn't she applied for the test. She waited and waited and waited. And it was like 9 months later, she comes to me and says, I never got my test date. What's going on? And I said, oh my gosh, 9 months. You didn't get your test date. What happened? And I said, did you get any emails from Prometric? She says, yeah, but they really didn't have much in them. Did you open the attachment? She says, no, I don't open attachments from anybody. Her test date had come and gone like 8 months ago. And they don't give refunds. So she was out $155. So make sure you open the attachments. All right. So tonight you have 2 chapters of homework. You are going. Oh, okay, Deborah. We'll talk about that in a minute. So tonight you have 2 chapters of homework. You have chapter 5 and 6. 5 is on dementia. You're going to have a lot of dementia patients. Pay attention to that chapter. 6 is going to be on skills. We're covering skills in class, but anything we're not covering in class, you probably want to read over, like shaving or showering in a shower. So it's just going to go over some general safety tips and things like that. So make sure that you read chapters 5 and 6 in your yellow book, take the tests for 5 and 6 in your white book, and grade them. So Deborah asks, hello, teacher. I got tested 3 times. I want to go back. What do I have to do? So if you took the test 3 times and you were unsuccessful, you failed 3 times, you are going to have to go through a 120-hour state-approved CNA program to be eligible to test. Or you can wait 2 full years from the date of your last attempt and you'll be eligible to retest. So you either go through a state-approved program to be eligible, or you wait 2 full years from the date of your last attempt to be eligible to retest. Hope that helps. Okay, you guys all have your review sheets as well. We're going to be sending out the after-class wrap-up emails in just a few minutes. You do have about 15 minutes of practice time today if you want to use it. I know it's not much. You will have some more practice time on Monday. So you'll be able to, practice the skills that we've learned. Does anybody have any questions for me?
So the smartest thing to do is start the process now.
Yes. If you register this weekend, if you do your background check and register this weekend, You should be testing about a week or two after graduation, which is perfect timing. That's why I usually hold off on test registration until week 2, because it's perfect timing. You want to make sure you've got enough time that you can practice and, you know, feel confident in your skills, but not so long that you've forgotten what I have said. So that's why I do this on week 2, class 4. I know that some of you have to wait for paychecks and other things, but if you're able to, do the registration process this weekend.
The whole graduation date you just said, can you explain when that will be and everything?
So graduation day is 2 weeks from today. And we don't do like a graduation ceremony or anything. If you guys want to bring in cupcakes or, you know, something like that, that's fine. It's your graduation. But I do give you folders and we talk about what your next steps are. But a big part of graduation day, we're going to talk about how to find a job in healthcare because it's different than other industries. We're going to talk about how to make a good impression during your interview. But we're also going to talk about things like continuing education, renewing your certification, how to, all of those legal things that we have to know, how to self-report, how to report address changes and things like that, how to move to a different state and transfer. I'm also going to help you answer that. You know, have you guys ever been on an interview? Anybody? You know, when they ask you, it's always a question on an interview. Always. Tell me a little bit about yourself. Everybody clams up. Everybody's like, I don't know. What do you want to know? I am going to give you a formula on the last day of how to answer that question. And if you use this formula, you are guaranteed to get the position because you will have a conscious way of answering that gives them the information they're looking for, and it'll put you head and shoulders above all of their applicants. So we're going to go through that on graduation day 2. Okay. Any other questions? All right. I hope you guys have a fantastic weekend. Do something fun, and I will see you on Monday. Oh, those of you joining us live, thank you so much for tuning in. If you didn't get to see the game show yesterday, go watch the replay. It was a good one yesterday. Some of those questions were tricky. Until next time, guys, happy caregiving. Bye.